Thank you, moderators. Now I would like to welcome Dr. Sandeep sir, HOD Department of General Surgery, to hand over the momentum to our MS. Now I would like to welcome Dr. Satyamurthy Aikal sir to hand over the memento to Dr. Francis Leo Thomas. Now I would like to welcome our Deputy MS, Colonel K. Kiran sir, to hand over the memento to Dr. K. R. Bhagwan sir.
Please kindly be seated. We will be proceeding with the inaugural ceremony, followed by a debate.
ಏರೋಪ್ಲೇನ್ ಮುಟ್ಟುದಿಲ್ಲ.
Good morning, ladies and gentlemen. We are about to begin, so please be seated. I, Dilara,
And I, Gagan,
on behalf of the Department of General Surgery, would like to welcome you all.
we appreciate you taking your time off of your busy schedules and joining
Both speakers and moderators. As it said, gaining knowledge is wisdom, and sharing it is first step to humanity.
India records one of the highest cases of polytrauma cases in the world, and only less than one-third of these cases are brought to the casualty within the first 3 hours. And this fact has been reinstated by our previous two speakers also. And this creates a necessity to understand managing such cases in a higher level. And that is what our CME will try to achieve by the end of this day.
Now I request our volunteers to escort our beloved dignitaries onto the dais. Our medical superintendent, our beloved dean, our medical superintendent, our chief guest, Dr. Sri Ram Bhatt, who is very popular among medicos for being the author of SRB, and our HOD of General Surgery Department, Dr. Sandeep.
I now request Mr. Ahmed to deliver our prayers to the Almighty.
Assalamu alaikum wa rahmatullahi wa barakatuhu. May peace, blessings and mercy of the Almighty be upon all of you. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. ولنبلونكم بشيء من الخوف والجوع ونقص من الأموال والأنفس والثمرات وبشر الصابرين الذين إذا أصابتهم مصيبة قالوا إنا لله وإنا إليه راجعون أولئك عليهم صلوات من ربكم ورحمة وأولئك هم المهتدون. And surely we will try you with something of fear and hunger and loss of wealth and lives and fruit, and give glad tidings to those who are patient, who, when an affliction befalls on them, they say, surely we belong to Allah, and to Him we shall truly return. These are those upon whom rest blessings from their Lord and mercy, and it is they who are truly guided. Jazakallah khair.
Now I welcome our beloved medical superintendent, Dr. Devidas Shetty, for the welcome speech.
Good morning. Good morning to everybody. So, friends, this particular topic, the road traffic accident and management of polytrauma. So, this road traffic accident has been a major concern across, particularly the Indian subcontinent. If you consider a bit of statistics are going on, in 2020 alone, go back to 2020, because we don't have a statistics of 2021 yet. The country has reported, imagine, 151,000 fatalities. 151,000. Just imagine, total of 151,000 fatalities. Each year, about country-wise, particularly in India, 3 to 5% of the country's GDP is invested in the management of road traffic accidents. So that means roughly about 3 to 5% GDP goes for the management of, account for roughly 6% of the global road traffic accident. So that means 1% of the world vehicle population in India, 6% of global road traffic accident. Unfortunately, 70% of the involved one are younger one, and particularly more of these accidents seen in the two-wheelers. So presently, so it all started, COVID was started somewhere in 2020. Presently, road traffic accident is more serious in India rather than the COVID, because the people dying because of road traffic accident per day in India is roughly about 415 deaths every day. That is more compared to COVID deaths, remember that. So in any accident, if you consider the accident as a whole, in accident we put it as early 1/3 and the middle 1/3 and the later 1/3. The first 1/3 will die. Anyhow, they will die. Whatever you do, they are not going to make it. So we don't give much importance to those who are severely injured in the spot. And the last 1/3, they die in the hospital because of the various reasons. But the middle 1/3 is our target group. That means these are the one we can definitely save them with our effort. This particular initial 1 hour of management is already, now we call it as a golden hour in the management of trauma. Already it has been discussed by our Dr. Augustine. Friends, when I requested Professor Sri Ram Bhatt to chair this particular function, he readily agreed without looking back. So in spite of his busy schedule, so he has accepted our invitation to chair this function. From Institute of Kanachur Medical College and also from the Department of General Surgery, Kanachur Medical College, I would like to welcome you, sir, for this function. As a token of respect, I request Professor Aital to hand over a bouquet to our chief guest. Thank you, sir. As we approach management regarding our CME, we want to conduct the CME. They readily agreed and extended their full cooperation to conduct this CME on behalf of Department of General Surgery. I would like to thank our beloved chairman, Monu sir, and also young dynamic director, Dr. Rehman sir. And in all our functions, our favorite beloved Dean is always there to support us, and very much cooperative, and he was very, very helpful in conducting this CME. I request Dr. Kiran to hand over a bouquet to our favorite Dean. I also extend my warm welcome to all our faculty members and the guest speakers, today's guest speakers, and also faculty from the other colleges as well. And I welcome postgraduates from different colleges who are attended here. And last but not the least, a warm welcome to our interns who helped us really in a big way to make this function a grand success. Once again, thank you all for making this function a grand success. Thank you. Thank you.
sir to hand over the bouquet to Dr. Sandeep, HOD of General Surgery Department. Now I request Dr. Satyamurthy Aikal sir to hand over the bouquet to our medical superintendent, Dr. Devidas Shetty.
Thank you, sir, for your warm welcome. I would like to request all the dignitaries on the dais to lighten the lamp and officially inaugurate today's CME. Thank you, dignitaries. Now I would like to request our chief guest, Dr. Sriram Bhatt sir, to enlighten us with his words of wisdom.
Good morning, everybody. First of all, I thank Sandeep for inviting me here. A few days back, he called me and told about the CME because probably it's the first CME physical one since last 2 years, the post-COVID session in Mangalore. So certainly I agree because physical CME always better than because we got some interaction, we can see faces. I certainly agreed to chair a first session, golden hour. All of a suddenly yesterday evening he called, you have to become chief guest. This was not suddenly, it was a surprise to me. Because I told him I am basically a writer, not an orator. He said, it is okay sir, you come here, people want to see you. I agreed, it is my honor to be here. I am very thankful to him for inviting me. I am here as replacing Dr. Ashok Hegde, who supported the chief guest, my good friend. Probably I can call me as a golden hour chief guest. Certainly, the two friends actually. I know Devidas Shetty because he has been with us. Sir, Dean sir, Professor. Of course, Sandeep is my good friend. Satyamurthy Aikal sir is my senior to me. Bhagavan, Eril, Rajesh is there. We are together. He's a good orator. I really appreciate his close friend of mine. Harishchandra, Rashekar is there, El sir, John sir is there. Most of the people I know, my assistant professor, Bhargav is there. My postgraduate, few of them have come from games in Mangalore. Of course, undergraduates and postgraduates of the different same institute and maybe from different institutes of other colleges in this part of the country. It is a nice program, and I don't want to waste much time, but I want to highlight in the three aspects of the current medical education system. Three aspects actually. One is medical education system. What we have seen, our colleagues like where I mentioned, our era, basically on that time, medical education was patient care, teaching. It's the main pillar of strength. And we have not much bothered about publications or research. We used to do somewhere, sometime, but we got our promotions up to professor, after HOD also without any publications much. They are not asked for that, without any research backup. But currently trend has totally changed. It is not just patient care and teaching. Of course, it's very, very essential. system has changed with the publication, research, academic oriented guidelines have come from NMC or MCA, whatever we call. You have to follow. That's the dictum. So there's a two parts in the system now. We cannot forget, like Rajesh rightly told, clinical surgery is a very, very essential. It's a pillar. If you forget, definitely, because basically we treat, all of us know that by experience, we treat the patient based, not just based on the imaging or X-rays or CT scan, even though that's what our postgraduates sometimes tell. We treat patient based on our analysis, imagination. As I said, imaging is later, imagination is better. You have to imagine every patient, you have to analyze, you have to assess the sequence or consequences of the what will happen if you do like that. So there are so many treatment strategies for one condition. You have to select what is suitable to that particular patient. So clinical examination, clinical assessment, clinical analysis, this is the basic pillar still holds good or essential to treat a patient at any scenario, post-op complications, acute cases, critical care patient, trauma patient, and so on. So this is additionally we have to do, of course, current requirement, guidelines, publications, research, academics, CMEs, workshops, all also very, very essential as far as progress at your own level to see the higher level of your professional or surgical career. Second thing, like the trauma. Polytrauma is conventionally defined as a trauma of the two systems or more than two systems. Conventionally, there may be changes. This is what conventionally we consider. Polytrauma is a trauma of the two systems or more. Maybe head, maybe chest, maybe long bones, maybe spine and so on, whatever they in earlier two sessions. Now, what is lacking in our country or in developing country as a whole is victim. If there's a victim, victim should be carried. Somebody has to receive it, maybe volunteer. There's a very poor volunteering system or carrier system in our country. There are so many problems with that, because if I see an accident patient, I may not go for that because I am worried. Not that I am not concerned all those things, because I have to sign somewhere, I have to attend police people, I have to face so many consequences, I may have to go to court. So many problems are there. So that's why we avoid victim. We'll think that somebody else will do, my job will be, otherwise my work will be difficult, all those things. So that is the problem. Second thing is logistics. To get the patient or individual trauma patient from the site to the nearest place where you can do whatever it is, golden hour, pre-hospital stay, all those things. So carrying all those things, that time is very crucial. That is not at all in this country. Maybe few cities like maybe Delhi, Kolkata, few places maybe it is. Still it is in a very, very rudimentary state. Third thing is, of course, golden hour, ABCD, primary survey, secondary survey. So the basic thing, even in our, we are conducting a critical care course, all India actually regularly. I am the vice president of that association. And ABCD and primary survey, secondary survey, the pillar of the teaching of that. Same holds good to the ATL. Little different between ATLS and ACCC. The ACCC is the beyond 6 hours. It's here only 6 hours. ATLS only holds for 6 hours. Anything beyond may not come under ATLS. ATLS is beyond, ACC is the beyond that, also it holds. So the difference between two. So acute, the ABCD is the current thing everybody has to remember. That's how you have to follow any trauma patient. Now additionally, it is not just physical trauma to the patient. It's a mental trauma, otherwise called the polytrauma stress syndrome. It is not only mental trauma to the patient, it's a trauma to the family, trauma to the social system, it's the economic trauma and burden. All are considered as a trauma. Finally, they will drain many effectively, because polytrauma is not easy and they need to have a hospitalization, they need to have enough transfusions, maybe blood, the FFP, platelet and so on, and also antibiotics, fluid, ICU care, everything extracts money. So that is also economic aspect, also very, very difficult to face by the family. Social system is altered. So because of the real mental trauma, not only patient, also to the family, to certain extent social system. So that also has to be addressed when you think about the polytrauma. Now, third part I want to discuss mainly for undergraduates and postgraduates, maybe young surgeons. As a surgical consultant, as surgeon, maybe general surgeon, you cannot consult. There is a two words you have to remember: job and work. Job is very simple one. Your owner will tell, do this one. You have done, do your work, you get your salary. That's a job. You don't have to worry about the implications of your what you have done. So work is very, very wider aspect. You are allowed to do, allowed to analyze, allowed to do that, allowed to change your approach, allowed to implement, allowed to execute. So you are much, much wider than just a job. So any surgical consultant should do work, not a job. Job is not possible at all because you have to get involved. Surgical system is the involvement, dedication, hard work. These three things are very, very essential. Unless you do these three, you will not succeed. You don't require a very, very intelligent person in our system because they are dangerous often also. And we need enough intelligence. Everybody is more than sufficient. What is needed is involvement. You do get involved. You can't say I am tired today, tomorrow I'll see. It's not possible. You need to get involved, especially youngsters. You need to be optimistic. You need to be dedicated. Hard work. That is the insight of our surgical profession. Of course, with the clinical surgery, all those things. So, my good students, my dear friends, this is what I say, three aspects. Change in medical education, you have to change ourselves to suit that. Polytrauma, of course, we are going to discuss in different sessions. Of course, mental trauma is the most area. And additionally, we have to always need to worry. And third thing is, surgery is a work, not a job. So always take home message, you have to remember that with the involvement. So with these 3 points, I hope I conclude my remarks. I thank Sandeep for inviting me, and of course, Kanachur Medical College staff, Dean sir, and of course Devidas and all others, and students, dear students. Thank you very much. Thank you.
Thank you, sir, for enlightening us with your motivating and inspiring words. Now I request our beloved Dean, H.S. Virupaksha, to address the gathering.
Good morning, everybody. Chief guest of the day, Dr. Sriram Bhatt. Distinguished invited speakers, observer from Karnataka Medical Council, delegates, the trustees, Medical Superintendent Dr. Devidas Shetty, Deputy Medical Superintendent Dr. K.J. Kiran, Chief Administrative Officer Dr. Rohan, Honorable Organizing Committee members of the CME, Professor and HODs, teaching, non-teaching staff members, my colleagues, friends, interns. Distinguished invitees on the dais and off the dais. Ladies and gentlemen, very good morning to one and all. On behalf of the management, staff, students, I extend a warm welcome to all of you to Kanachur Institute of Medical Sciences. On behalf of the CME organizers, I would like to express my most sincere gratitude to all of you for your presence at this inauguration, who have come together here from various reputed polytrauma. We are indeed honored and especially thankful to our chief guest of today's deliberations, Dr. Sriram Bhatt, who is amongst us in spite of his busy schedule. Many of the dignitaries, resource persons who are also sharing their time with us in this event have changed their previous commitments, professional duties to find time to render stimulation and appreciation to the participants. I also welcome the delegates who have joined us from various institutions. The theme of today's CME is on the medical team's response in treating the patients who approach a hospital with polytrauma due to either accidents or disasters resulting from either natural or man-made. Both these kind of disasters are unpredictable, dreadful, and may even end up in tragedy. I am sure that today's deliberations will enrich you with the latest updates to handle these situations in a better way. May I take this opportunity to congratulate the Department of Surgery for organizing this CME under the able guidance of our Professor and HOD of Surgery, Dr. Sandeep, and his team of surgeons consisting of Dr. Devidas Shetty, who also Professor and Medical Superintendent, Dr. Satyamurthy Aital, Professor, Dr. Dharmadev, Dr. Kiran, Dr. Likith Rai, all Associate Professors, and Dr. Rashmi D'Souza, Dr. Ravi Verma, and Dr. Abhiram, all Assistant Professors. Regarding the academics, the first batch of MBBS students were admitted in 2016. Subsequently, the institution got permission from the erstwhile Medical Council of India for 150 admissions every year without a break. I am happy to share with you that the first batch has passed the final MBBS exam with 98% and has been recognized by the National Medical Commission. I take this opportunity to thank all the teaching staff and the non-teaching staff of this institution for their efforts. I am pleased to inform you that the National Medical Commission has permitted the institution to start the postgraduate courses from this academic year in general surgery and general medicine, and we are awaiting the permission for 8 other broad specialties. An onco-surgical unit was started, and I wish to inform you that the Oncology Board was launched last month as a new initiative in partnership with the esteemed Case Hegde Institute of Medical Sciences. I wish to thank the management for their constant support and help extended to conduct this CME. I am sure you will have fruitful and rewarding exchanges in the next few sessions. I wish the deliberations a grand success, and at the end of the day, I hope that you will all be well informed about the latest trends, more knowledgeable, and will be able to implement them in your day-to-day professional practice, either teaching or clinical. With these few words, I wish to thank the organizers for giving me an opportunity to stand before you to share a few of my thoughts. Ladies and gentlemen, thank you for your kind attention. Thank you very much.
Thank you, sir. Now I would like to request all the dignitaries on the dais to honor our chief guest.
Thank you very much for honoring me, Sandeep and Amit sir, and thank you to the college also. Thank you.
Now I welcome Dr. Satyamurthy Aital sir for word of thanks.
Good morning to everyone. I am here standing before you on this dais to perform a pleasant task, and that is to propose the vote of thanks. Dignitaries of the dais, my surgical colleagues and friends, and heads and staffs of various departments of Kim's family, our interns and delegates from various colleges, mainly the postgraduates. My wishes to all for attending this function. Now, first of all, I like to thank our Professor Dr. SRB. He is our Apat Bandhava because he has come to our rescue at the need of the hour, during the golden hour. So actually supposed to our Dr. Ashok Hegde, Dean of AJ College, had to come here because of the some emergency or something like that. He could not do it. So we have requested Dr. Rambhat. He has readily agreed, and he has been the chief guest of today's function, and he has performed his job very well. So thank you, sir, for coming and gracing this occasion. I thank our patrons, though they are not here today because of their prior engagement. So Dr. UK Haji Mono, our chairman and dynamic director, Abdul Rahman, with their whose support, we could able to conduct this meeting in this somewhat grand manner. So I thank them in their absence. I also thank profusely our Dean, Dr. Professor Virupaksha. So he has been the backbone to us, encouraging us and doing all the necessary things, sitting in his chamber, directing everyone to do the things in order. So, and also he has agreed to be the guest of honor today's function, and he is representing our Kanachur group of institutions. So thank you very much, sir, for being with us. I also think I will be failing in my duty if I don't mention about our respected MS, because he is the main person who given a good injection to all of us. Not COVID injection, some other good injections. He is the one because of whose inspiration, and he is the one who insisted that you should have this CME before the end of this month, October. So he called me one day. See, this is not right because management is asking to do conduct the CMEs, so we have to do that. Then I suggest that the Polytrauma is the only best thing because we can ignore so many people and we can make it to a somewhat expected level. We can take it. So he is the person. So sir, on behalf of Kanachur group of institution and also mainly the Department of General Surgery, thank you profusely, sir, for initiating us to take this venture. Then our dynamic HOD, Dr. Sandeep, yes, he is the one who assigned jobs to various people of our staffs, various staffs of our department to take the responsibility, like printing, distributing the invitations, getting the mementos done, all those things. Thank you so much, sir. Then I thank all our surgical colleagues, friends from various other colleges, HODs, then departmental staffs, then the speakers mainly. When we requested the speakers, so they are readily agreed, and everyone has come in time and taken part in this CME, and also the moderates of each session, everyone has been present here. So I thank one and all for coming here, sir, and doing justice to your role given. Then at the same time, I thank all our staff members, HODs, and students of various departments of cultural institution for being present here right from 8:30 here with us and making this function a grand success. And any program, as I said, without the participation of the delegates in large number or huge number, it won't be a successful one. So I see a lot of postgraduates from various colleges responding to our invitation and getting themselves registered and being present here. I thank all the postgraduates and delegates who have come in large numbers to grace this occasion. Thank you. And I should mention about people behind the scene, like Darshan, then Asghar. Those are the two persons who made all these arrangements, including printing them and getting printed the banners, then arranging the things here. Everything is done by them, and ordering, catering and other things, everything is done by them. So I should be thankful to them. And also, I should be thankful to all our interns for volunteering themselves. And also, I've been failing in duty if I don't mention about today's MCs. One is Voice of Tulnadu, Gagan, and Voice of Calicut, Dilara. So they have readily agreed to be here right from morning 8:30 up to 4 or 4:30 till this gets finished. So with their sweet voices, and I think they were very much audible to you all, I hope, and I thank them. And also I thank our audio-visual aid provided by IT department, all the backs, the setting of the stage and screen, everything. So I thank all of them, and I thank all the people who directly or indirectly involved with this unique CME which has been conducted today. So I thank one and all for being with us and making this CME a grand success. Thank you, everyone.
Thank you, sir, for proposing the vote of thanks. Once again, I would like to thank all the dignitaries for your gracious presence and words. This concludes our formal inaugural session. Now we'll be having a small tea break, following which we'll continue with the sessions. Thank you very much.
Thank you. Huh.
Hello. Hello. Hello.
Right turn. Pura off on, Pura off on, भैया. Pura off. Yeah. क्या बढ़िया हाँ ಬರ್ತಾನೆ ಈಗ ಬರ್ತಾನೆ ನಿಜದ ಪರವಾಗಿಲ್ಲ ನಮ್ಮನೆ ನಮ್ಮನೆ ನೋಡಿ ಒಂದು ಇಂಟಿ
Hey, namaste, boss. Big boss, how are you? Always there. You had a bite?
We are about to begin the next session. Please kindly be seated. We'll begin the session in 5 minutes.
Okay. Attention everyone outside the session will be starting within the next 5 minutes. Please occupy your seats. So with a standard dose of caffeine and a continuous infusion of attention and concentration, let's begin with our next session ASAP. The topic for our next session is approach to long bone and spine fractures. First of all, I would like to welcome our moderators, Dr. Salahuddin Arif sir, Professor and HOD, Consul Institute of Medical Sciences, and Dr. Mayur Rai sir, Professor, Department of Orthopedics, AG Institute of Medical Sciences.
Now I would like to introduce our very passionate speaker, Dr. Vikram Shetty, who is the professor and unit head of Ortho in KSLK. He completed his UG from MMC Mysore, his MD Orthopedics from JJM Davangere, his DNP from Shema. He was the gold medalist in the year 2005. He did his diploma in tissue banking from Singapore University. His special area of interest include arthroplasty. Now I request the moderators to be on the dais and begin with the session.
There are many more criteria actually to say about Dr. Vikram Shetty for that matter. It's not just his academic part, it's almost, it's a pleasure to introduce him basically. Dr. Vikram Shetty is known almost synonymously with the Department of Orthopedics in Shema. Many of you might not be aware of that. Of course, just now it was said, he was, as rightly said, he was the gold medalist for DNB Orthopedics.
for the district actually. The first orthopedician of this district to get a DNB gold medal in this. And all the orthopedic surgeons of this district agree that Professor Vikram Shetty is the backbone of the Department of Orthopedics in CME. He has contributed significantly not only for the growth of the department in CME, but has also contributed significantly to the academic fiesta conducted by Kendra Orthopedic Society and Karnataka Orthopedic Association. He has also contributed significantly to provide free orthopedic services to the poor people in the society. He worked with so many non-governmental organizations and provided free wheelchairs, artificial walking aids to the poor and downtrodden. He is also an executive committee member of Kendra Orthopedic Society and Karnataka Orthopedic Association. Now I request Professor Dr. Vikram Shetty to kindly deliver his talk on approach to long bone and spine fractures. Over to Professor Vikram Shetty.
Good morning, all of you. Respected chairperson, dignitaries, my friends, and dear students. Can I just know how many of you are undergraduates here? Can you just raise your hands? Postgraduates? Fortunately, yes, thank you. Because I was actually lost that when I was preparing the slides, I was not sure whether it was focused at undergraduate or postgraduate. So what I did is, my focus still remains the undergraduate, but I had a little bit here with masalas for our senior, that is the postgraduates. So for the staff and other dignitaries, please excuse me, this talk is not directed at you. It might be just here and you can just read from the other side. So Arif sir has given a few good words. I'm not sure whether I'm worth it, but anyway, thanks sir. So let's go with the straight away into the topic. Okay, this is my topic, approach to the fractures and spine injuries. My objectives for today is I'm going to give a few terminologies, because what happens is when casualty, the most difficult thing what I recognized is our students and our postgraduates fail to recognize the meaning of few words. We say this, that, and then go off within a fraction of a second. But actually when you look at, you come back and ask them, what did I say? They are at stars. I mean, they probably could not catch this word. So what I have done is I have kept very fundamental, basic terminologies for you to know what these are. I know these are very, very fundamental. Sometimes it looks like as if I am talking to a second year MBBS student, but it's okay, it's fine. Because unless you have your fundamentals right, it's very difficult for you to go ahead. So today's topic, whatever has been done by the Department of General Surgery from Kanachur Institute, is primarily to make you start this first baby step towards good quality care when it comes to polytrauma. So this is about terminologies. The first one is of course the fracture. So I'm not going to, you all know, but most important from the emergency point of view is to recognize whether there is any breach in the skin. If there is any breach in the skin, please recognize this is an open fracture and this needs little more attention than the other things. So the second one is the dislocation. Okay? You all know whenever there is a very gross deformity at the joint, most likely it is dislocated. But problem is sometimes they come to the casualty, they would have had a dislocation, they would have reduced on their own, and that is when you need to recognize that you need to take a better history to identify whether there is a dislocation before he reaches the casualty. Okay? So the last one is sometimes the dislocation is not reducible, and that is when you need to take the help of your staff or seniors. So few terminologies again. Sorry. Okay, sprains. Very commonly we say sprain. What is sprain? It is just a ligament breach. Fracture is bone breach. Sprain is a ligament breach. So commonly we have ankle sprain. You can have ecchymosis. There are various grades. So it is important to differentiate this word from a strain. Strain is a breach in the muscle. Of course, tendon can be part of the muscle, but this is particularly with respect to, I had a back strain. STRAN is different from SPRAN, that is sprain. Sprain, I am talking about ligament. Strain, I am talking about the muscle. Few more compartment syndrome. This is one of the few terminologies which sounds ringing bells to my ears whenever somebody talks about compartment syndrome in the casualty, because it's a dire emergency, because you might lose the limb. So they usually come with 5 Ps, which you all know. So any increased compartment following a trauma, which is either 6 hours or 12 hours, between 6 and 12, typically they come with, because most often what we see in this part of 3 medical college, which we call as medical street, we have these patients coming from long distance, traveling 5 hours, 6 hours after the trauma. When they reach our casualty, we have missed. I myself have missed a compartment syndrome and I have lost a leg. Okay, there is a possibility of this can occur to anybody. So be sure whenever they come, travel a long distance and come to you, if the duration is after 6 hours, keep this word in your mind, whether this patient has a compartment syndrome or not. So how do you recognize? Increased stretch pain. Whenever you stretch a particular compartment, imagine I am talking about the plantar aspect of posterior aspect of my leg. So that is a compartment where just do a dorsiflexion. If there is a pain out of proportion which normally otherwise would have happened, then keep in mind this patient could be potentially a case of compartment syndrome. The other thing which I want to stress is sometimes what happens, the patient would have, for example, a wall has fallen on the patient and the patient is like that for a couple of hours, and once they remove the wall and extricate the patient and get into casualty, then again you can have this. Just keep in mind. Okay? Splinting. We always say, okay, there is an injury, do a splint, send to X-rays if there is nothing from general surgical side or if there is no life-threatening injuries. So, okay, so you should know what comes when, which is a priority. Basic thing is, a splint is a fixed or a rigid device, flexible or a rigid, which is just to help to put this to whatever injured limb into a rest position. This is very important. We have seen problems occurring because we do not splint when the patient comes to the casualty. Of course, the first one is ABC, ABC, ABC. Morning you must have heard a lot about this, but that's fine. ABC is important. It is life and death question. So make sure that you all take care of that. Once that is done, then ensure there is no further damage to the limb. So make sure that you splint before you send for other investigations which are not so very important for after your ABCs are taken care of. So what is my target as a doctor or from the orthopedic point of view when I be at casualty when a multiply injured person comes to you? I should make sure that there is no further injury. I should try to minimize pain maximum. Give cold packs, ice packs wherever possible, analgesics. Make sure that if I am say for example tomorrow once you finish up from here, you are in the practice a small setup where you do not have adequate facilities and you need to transfer the patient. Make sure that this patient gets the best treatment. It is not that you should treat every patient. It is important that not you which is important. It is the patient which is important. You should see whether this patient gets the best treatment in my hand. If it is going to get the best treatment in my hand, please treat. Otherwise, refer. This could be little opposite from some of the seniors who would probably argue that we should be independent treating everything. But I disagree. I say, for me, my patient is most important. In the sense, what is important for that particular patient, you should give the priority. It is not that my hospital or my clinic should treat everything. It is not like that. Whether if you can do, give it, no problem. If you cannot give it, make sure that you refer to a center wherever the facility is available. Do not deny a patient a facility to treatment where he can have a better outcome in his life. Long-term disability is one of the most devastating problems in orthopedics. Of course, if life survives the first few golden hours and after that, then comes the problem with the disability which they are going to leave it for lifelong. So, the second part of which after the terminology is the assessment. I know there are few slides which will be repetitions. Sometimes reinforcement is very important because you know this word has been coming on and off even in our SR-based talk. We raised this, I am a golden man here. Yes, he is a golden man because for this function, but there is a golden hour for this polytrauma patient. So you should take care of those hours. I am aware that there are certain people who say this golden hour no more exists. Every minute also is also important. Prolonged hypotension can cause significant damage. Any suspected open fracture or vascular injury is a medical emergency. Other than that, there is nothing much from the orthopedic side. The first one, hypoperfusion, we only think about pelvic fractures which can cause death within first few hours. Or a vascular injury which you need to do a priority. Otherwise, if you look at a casualty, any polytrauma community, primarily it's a responsibility or it's the solid organs and other major things which general surgeon usually take care of as a team leader. Once they have taken from our side, what we see is only this. And most other injuries of orthopedics are not critical. I hope you are clear by the word critical. It is important but not critical. So these are the basic few steps. This comes in different forms and shapes. The first speaker would have given in a different format, second speaker would have given a different format, I am giving a different. But essentially, if you look at everything, follows the basic scene, basic this setup. Scene size, see whether it's a single person coming is the mass casualty, you need to plan yourself, primary assessment, history taking, secondary assessment and reassessment. So this is a various format which we normally see. Most important is you should look at the bigger picture. Normally what happens is very commonly we miss thinking that, oh, this fellow is walking. He may be walking around, but he may be dead in few hours if you really don't recognize that he could be having something more serious. So essentially, you should be able to distinguish the mild injuries from the severe injuries, because severe injuries can be at times be life-threatening. Okay? Of course, see, whatever I am trying to put is only from the orthopedic point of view. Please, because there are points which are trimmed out because other things are taken care of by the other speakers. So from the orthopedic point of view, whenever there is spinal injury, we are more worried about airway breathing. If you are talking about C1 injuries, cervical C2, C3, these are the injuries which you are worried about, because if they have a paraplegic or a quadriplegic below that level, they are likely to have a problem with the respiration. That will come in and see in the next slide. So once there is a green flag which is flagged by the general surgeon or the team leader at the casualty, then comes our role to identify whether there is any other injuries, hidden injuries which we normally miss out. And typically this is the word, we'll do a full body scan. I mean, what is a full body scan? We take x-rays from top to bottom. No, it is not like that. Please, the word full body scan means you have to do, if you remember SRB saying, you have to examine yourself, you have to take history. It is not that you put x-rays and then see where the fracture is. Definitely not the way to go. You have to clinically examine, see from toe, head to toe, whether there is any injuries. You go in a systematic fashion. The commonly what occurs in the casualty is patient comes with a broken hand, they come sit in front of you and you examine only this, write this x-ray. Once he comes back, then he says, I have pain here. Then he says, I have pain here. Please don't do that. Then he send again back to x-rays. It's not the way. You need to exactly go for this. Otherwise, then you will have problem of missed injuries. These missed injuries are your dash visiting cards. What are those? Any idea? Every patient is your visiting card. All of you agree with that? Only these good patients who keep on telling everybody, okay, this doctor is very good, this hospital is very good, this setup is very good, please go there. They are visiting cards. But a missed injury is a bad visiting card. You have one miss, it is like you doing 100 good things for the society. Please remember, do not have any missed injuries. So be careful that you do not miss out anything. Lacerations in any extremity, make sure that there could be possibility of tendon injuries, bone injuries or neurovascular exam. Don't simply suture without keeping a thought for these more serious injuries. So when there is no life-threatening injuries, make sure that you take little extra time to stabilize the extremities and then do the further things. Because a stability by giving a temporary splint itself can sometimes save a limb. So primary care we do, of course, this is one of the things from the orthopedic. If there is a bleeding, you can just put a pressure, put a bandage, elevate it. Most of the time it does stop. If it does not, then sometimes, very rarely, you might need to put something compression above that. Okay? So keep in mind a simple compression bandage will take care of your most of the bleeding. A splint, it is mainly important to prevent damage to the muscle, the spinal cord. If you are looking at the spine board, then it could be peripheral nerves. It is mainly to prevent all these problems. Splinting is very fundamental. Do not take any x-rays without any splint. In our department, if any PG has taken an x-ray without a splint in the x-ray, that he gets missed, 100% sure. What is going to get? Any idea? No. We have a big fat bank account. It's going to deposit money to the poor patients. Okay. So what are the basic principles of splinting? So we need to remove the clothing from the area, note and record whatever findings is there, because once you splint, it's all closed. it's not a bad idea to take a photograph, preferably with the consent of the patient, and keep it. Because once you put a dressing and your consultant comes next, and no need to open it again, you can just show the photograph. Most often it is enough. But please take a consent, that is point number one. Second thing, do not share it to anybody else other than the medical records department. If you can't take care of these two, don't do that, because you may be in soup tomorrow for taking illegal photos. Third one is cover all wounds with a dry, sterile dressing, and do not move the patient before splinting to the extremity. Then there are a few more principles. Pad all the ridges. Sometimes we have the splints which are metal ones. If you don't pad, the splint itself can cause injuries. You need to maintain inline stabilization. Like for example, if I have to put in a cervical collar, I make sure that I hold the head properly, so that when I am putting the splint, I don't rotate and then cause further injuries. That is not allowed. So you need to maintain the inline splinting, do a stabilization with an inline this one. Resistance. Sometimes when you put a splint, there could be a lot of pain and resistance from patient. So in that condition, it's okay to splint in a deformed position. No need to do heroism there and try to correct a very deformed fractures, which can sometimes be counterproductive. Stabilize. All patients suspected spinal line should be stabilized on a spine board or whatever you think of, and then be shifted for further this one. These are the basic principles of splinting. So, for example, there is a fracture out here. You have this limb which is fractured femur and it's gone off. Just pull it in that direction and push a Thomas splint, and usually it falls in place, and that itself is enough. This is called inline traction splinting. Most of the fractures are taken care of with this. Oh, this is a classical example of Thomas splint with the traction. Okay, what is the idea behind this? It is to stabilize the fracture fragment, to align the limb as much as possible to avoid potential neurovascular compromise because of not splinting and having further problems. These splints, which are called Thomas splints, are available in most of the casualties in good numbers and various shapes and sizes. So we are not going to go in detail about that, but these are important things which are armamentarium for your management. Then you have these ready-made splints which are called flexible splints. These are malleable, you can adjust and do whatever you want. Like if you want to put it here, you can bend there and do. These are disposable ones, or you can reuse if you maintain it in a good place. And they can be used whenever there is a small fracture, if you are not very keen in inline fractures. Only thing you need to maintain two things. When you're putting a rigid splint, if there is severe gross deformity and if there is a lot of resistance or extreme pain, be cautious when you're applying splint for this, because you might be doing something counterproductive. This is very important. I just highlighted here. In orthopedics, we have only one emergency. Is there a pelvic fracture? Is the PP is low? If these two things are there, then the first thing I should do what I call a pelvic binder. You take a bedsheet which is available in the sister's counter, fold it so that you get around 1 feet width. Keep it underneath that and take the first fold and take this overlap, double breasted. Once you do that, you put two towel clips or the straight arteries to keep it closed. Normally, we see a pelvic fracture patient can bleed to death, and it's primarily because of opening up all the venous channel which does not have compression to stop. To give an incidence that what happened during my post-casualty, when one of my co-PG, one of my senior who wanted to see the classical pelvic compression and distraction test, he's a hefty fellow, big pump, he's no more now, but what is important, he came in front of me, the patient was there, admitted yesterday night, it is fine, all fine, case sheet, everything written, only waiting for surgeon to come. He came and he did like this and did like this once. He just wanted to test the compression and distraction test, and the next minute, unfortunately, the patient is no more. It can be as serious as that, because we should know all these tests, provocative tests, whenever we are doing, we should be very, very, very gentle. Transportation caution. Very few, if any, muscular injuries justify use of excessive speed. We have seen ambulances rushing out from here to there. We are pushing the trolleys in extreme speed. It is not required. You should know you might cause more danger. Only if you are looking from orthopedic point of view, there are only two times when you need to be little more cautious when there is a pulseless limb, or if you are referring to a center which is very far, few hours, probably the speed does matter. Otherwise, it is more than the speed, your brain and your presence of mind at that particular point of time which is going to save patient and patient's life. And Special situations, just to give an overview, as I already said, this test, be careful. So pelvic fracture is one thing which can cause life-threatening injury. A simple double breasting using a bedsheet can save your life. There is nothing more to be done. If beyond that, then it requires they will do an external fixator or orthopedic surgeon or whatever it is, they will do it. But primarily you need to do is in the emergency is to put a binder. Femoral shaft fractures can be at times very problematic in casualty because a femur fracture can bleed up to 1 to 1.5 liters if you are not taken care adequately. You can have hypotension. Most important is to recognize an open fractures. At times, you will be continuous loss of blood and you should need to take care of them. Neurovascular injuries also are very common associated with femur fractures. You need to take care of those two also. Okay? Open fractures, nothing much. These are only problem is when there is a lot of blood loss can cause problems at day one, or they are the ones who are actually looking at, if you look at disability in the long term for the patients, these are the ones which actually reminds them of the accident for whole of their life, because we are not able to give perfect treatment or 100% treatment in most of these open fractures. So these are the various organisms which your history will guide you to tell which antibiotic to start in the casualty. Unfortunately, we have this triple shot. I don't know whether it's still followed or not. We still have, without even recognizing the history, we just say fire 3. Okay? Which are the 3? Anybody? Okay, anyway, different hospitals could have different protocols, but I'm not going to go ahead. What most important is, don't simply start antibiotics without knowing what the history is, what the source is. If you are looking at a form-made injury, you should target your antibiotics towards that. Otherwise, if it is just a closed fracture, a small puncture wound doesn't require that many antibiotics, because you might end up in having problems for next generation. If you look at the infection, it's only 18% of the cost of same or usually isolated before this one. It's most often nosocomial infection. So you are giving antibiotics left and right on admission, you should think. But at the same time, I'm saying you need to, most important, to cover the wounds quickly. That is very important. Okay, you are leaving the wounds open for a long time is an invitation for your enemies to join the patient's body. So when do you give? If at all you are going to give as soon as possible. Preferably if you see a wound, please give it as early as possible, because we give antibiotics earlier, definitely it's going to make a lot of difference in the outcomes of the patient. But that doesn't warrant you to blindly give the triple shot for everything which there could be no indication. Last little about spinal injury. So most important for you to recognize is spinal injuries normally are missed very commonly. If you ask any orthopedic surgeon out here, all of us have missed spinal injuries. If somebody says they have not missed a spinal injury, it clearly means only one thing, that they have never ever treated any patient. Because otherwise impossible. Everybody would have missed a spinal injury. So if we have missed, if sir has missed, so there is high chance that you will also miss. So make sure that if these histories are there, you need to be very sure that spinal injury is not there. So unconscious patient, very difficult, because they come with airway breathing problems, they get intubated, then you have no chance for you to evaluate, then it's very difficult. If there is a neurological deficit, yeah, of course, yes, then it becomes more easy. So it's missed or delayed diagnosis mainly because of failure to suspect injury, because our brain should keep on asking, is there a spine injury, is there a spine injury? Because if you keep on asking, then there is a possibility for you to recognize more and more cases of spine injury. And inadequate radiology does not mean it's the radiology department is at fault. It's not. It is the per se where, because if you want to see cervical spine X-ray, to take a cervical spine X-ray in a lying down patient is very difficult. You have to go and see and take once and see how many vertebrae you will be able to see. Most of the times you missed out C6, C7 injuries because the shoulders overlap there and there is a possibility. It is nothing to do with the radiology. Inherent problems are there, so you should be very careful. Incorrect interpretations is one of the things which again can improve. All of us can make an effort. Missed injuries can have a devastating long-term consequences. So spinal injuries must be presumed unless until it is excluded. You understand? I hope you are clear. You should assume that every patient has a spinal injury unless until it is clear that there is no spinal injuries. They have, sometimes when they have the quadriplegic, they present with this triad of hypotension, bradycardia and hypothermia, which is slightly different from all the hypertensions what you get in casualty. Because in all casualty you get tachycardia, right? Am I right? But here is one which is make you sure that there is something, there must be a spine injury, because they would have gone for a neurogenic shock and they have bradycardia. So just because bradycardia, don't think this patient is not a shock. Okay, when you think of spine injuries, most important is spine, whole spine to be immobilized in a spine board, preferably with a rigid cervical collar wherever possible. And you should know something called as log rolling. What is log rolling? When we roll a log, whole thing from the top end to the bottom rolls in one push. So here also we should be sure that when you're rolling a patient, you should roll as if you're rolling a log. That means somebody should hold the head till the toe, and together 4 or 5 people, depending on the weight of the patient, you should be able to roll it. But most important is you need to keep the head in line with the body. So that holding is very essential. If you don't hold, then the neck will be here, the body would have gone there, then you are actually causing more problem than actually what you actually intend to do. So protection is a priority. Spine protection. Detection of spine injury is not a priority. I hope I am clear. Protection. So you need to protect till you detect it. Detection comes secondary, protection is primary. So spinal immobilization is a priority. Clearance is not a priority. You can clear after 2 days also, absolutely no problem. As long as you can take care of that immobilization part with you. Imaging of the spine does not take precedence over life-saving procedures, because we have seen our PGs fighting in the general surgery PGs. No, you should get spine X-ray, you should get that X-ray. No. There are only 3 X-rays which are allowed: cervical spine, lateral, pelvis and the chest. The rest is not emergency. It can be done later on. There is no hurry. Okay? So very rarely, from the orthopedic point of view, you can need a ventilator support whenever there is an injury higher than this level. So higher than this, I'm talking about C1, C2, C3. After that starts the diaphragm. Above this, you can at times need to prophylactically ventilate this patient, otherwise this patient may not make it till the end of the day. So last one, because I have had problems with this, so I thought I'll just put one slide. Because now in Mangalore we have a lot of these microvascular surgeons who come and rejoin the parts. Cut off parts, they rejoin. Very commonly, they have a small sore. So I thought on behalf of them I'll make this clear. Whenever there is an amputated limb or a severed limb, we should know how to take care of it. And for your kind information, most of the hospitals in Mangalore are doing reimplantation things. So nothing to worry, it is possible. It's only the duration and the severity and the part. It depends where is it. Some of them have wonderful results, and we have seen all over our life. It's because of the new generation doctors who are well trained in this microvascular surgery techniques. They are doing this. So we should ensure as much as possible, try to help them with proper, when you're setting this part, it has to be set in proper way. If there's a gross contamination, you can clean. Even if you don't clean, it's okay. Make sure that you just wrap in a moist gauze and then put it in a plastic sterile container if you have. Otherwise, just put it in a plastic bag and tie it. The common mistake what people do is take this and put it into the ice directly. Don't do that. You should not take the part and directly put it into the ice. If you put that, the whole part gets frozen and it's gone. So important is to put it in a plastic cover, gauze road, then to the plastic cover, and this part has to be put into this. This is like you pack fish. You know, if you are traveling for a long time, long duration, you should know how to carry fresh fish. It's like exactly the same way. If you put directly fish into the ice, your results don't come well. You take it and tell your whoever you want to tell this. Okay? So, in brief, my last slide. The 6 phases of trauma care management include the following things, and you all know what these are because they have been repeated from morning again and again, and after me, Shilpa is going to come and tell that again the same thing. So, take care. Phase 1 triage, see whether a single person who is coming in or multiple person coming, you should know how to triage these people. Primary survey, resuscitation, secondary survey, stabilizers, transfer, definitive care. Okay? It may look ridiculous because every speaker is coming and telling the same thing again and again. It's okay even if you shout at me, I still want to repeat this again. It is first is triage, second is primary survey, resuscitation, secondary survey, stabilization, transfer and definitive care. Okay? With this, did I scare all of you about getting treating patients in casualty? If you think I'm scared, okay, I just have a small video for you to show a little person can make a lot of difference. Okay, with this, I thank the General Surgery Department for giving me this opportunity to come over here. This is my second talk in Kanachur. Nice to come back to Kanachur and give you a talk. Very nearby, we can save a lot of time. And this is the video to show how much a little confidence can make a lot of things better in your life. And just to chill out a little bit. Thank you. I'm sure you must have enjoyed that speech. It's not my talk, at least this clip would have given some class. Thank you. Any questions, anything? Because I may not be visible after another 15 minutes. Any thoughts, any questions from this talk? If I can't answer, my bosses are there, they will answer for you. Don't worry.
No, very nice talk. This is just to add on to your lecture. This reminds me about your patient is your ambassador.
Exactly.
That is your visiting card. I still remember one of my surgeon operated on ex-CM. He is no more anyhow, Mr. Bangarappa.
Yeah.
The one who operated was a ENT surgeon. He had mastectomy. And he was an ambassador till he died.
To explain what he said, I think these people may not be aware who Bangarappa is and what his face was. He is talking about your patients are your ambassadors. Even if you make a mistake, that mistake will be there for your whole of your life, or even until that patient dies. So either you should die or the patient dies. So you should be very careful. Whenever you have a patient, do not miss anything, because they may be a good ambassador or a bad ambassador, both ways.
Yeah, still those who have not followed it, it was a surgery done for a mastoiditis. Okay? So it's a very difficult surgery. Those days we didn't have microscopes and all. Injured a facial nerve, LMNT. Okay? Once you have the facial nerve, that's the end of your career. He will remind you everywhere.
Okay, thank you, sir. Fortunately, they are not average. Any other doubts?
There are no doubts. Then thank you, Professor Vikram Shetty,
Thank you,
for
sir.
that lucid talk and keeping all the audience mesmerized.
Thank you very much.
Thank you, sir, for your information.
Also, I thank Professor Mayur Rai from AJ Institute of Medical Sciences for coming here and moderating this session.
I request the moderators to present the memento to our speaker as a token of appreciation.
Now I would like to request Dr. Krishnappai sir to hand over the memento to Dr. Harif sir. Dr. Mayur sir. Dr. Harish Hegde sir, Professor and HOD of Yenapur Medical College, has joined with us right now with the CME. So I would like to welcome to this occasion. Welcome, sir. Next up in aid of our polytrauma patient is one of the youngest departments that within this millennium rose to become one of the three important A's, that is asepsis, antibiotic and anesthesia. The topic for our next session is anesthesia in polytrauma, and to moderate this session, I would like to welcome Dr. Vincent Matthias, Professor and HOD, Financial Institute of Medical Sciences, and Dr. Malati Ma'am, Professor, Financial Institute of Medical Sciences. I request the moderators to please occupy your seats on the dais.
Small change that Dr. Malati Madam instead of Swami Pula is coming. Some small change.
I welcome Sir
Swami, yeah.
Now I would like to Dr. Shilpa. She's assistant professor at the Department of Anesthesia in Empire Medical College. She did her fellowship in trauma and regional anesthesia from Ganga Hospital in Coimbatore. She, in American Heart Association BLS and ACLS instructor since 5 years. She has 5 research publications, 4 national and 1 international. She also presented in national and international conferences. I welcome you, ma'am.
The role of an anesthetist in the theatre is one that of a kingpin. Now, many of us, the old timers would know what a kingpin is. Does any of the interns know what a kingpin is? You know, these trucks have wheels. The truck wheel has something called as a kingpin. The kingpin is actually the cotter pin that goes and it directs the direction of the wheel. So the role of an anesthetist is very important in the OT and which will determine the outcome of the patient. We welcome you, Dr. Shilpa.
Thank you, sir. Good afternoon all. I'm really sorry for the initial technical glitches. I bring with me wishes from our neighbouring medical college, Yenapaya Medical College Hospital. It gives me immense pleasure to deliver this talk here today, and I'd like to thank the organizing committee for giving me a chance to deliver this talk here today. Being the youngest speaker of the day, I would be lying if I deny the fact I'm I'm pretty much intimidated by the brilliant talks given prior to this. But being an anesthetist, that's what we love, right? The adrenaline rush. No adrenaline rush, no fun. So to begin with my topic, anesthesia and polytrauma. So a very interesting and a challenging set of patients when it comes to the anesthetist. Usually when it comes to the management of polytrauma, anesthetist is the first person to reach the scene. So here we have already had a surgeon, orthopedician and also emergency physician here before us. So they have pretty much covered everything, making my job much easier for me. Since my target audiences are like undergraduates and postgraduates, I've kept my topic sticking towards more of basics. If I ask how many of you all have actually attended a anesthesia posting, I'd be embarrassing myself, so I'm not getting there. So we'll stick more of to the basics so that you can understand what I'm trying to talk here. So to begin with, anesthesia and polytrauma. So trauma is a major public health concern owing to its long duration of hospital stay, increased cost and also associated morbidity and mortality. So trauma is the leading cause of death, especially in the age group of 18 to 44 years, and if we include all the age groups together, it's the main cause of death. Trauma accounts for almost all 30% death that occurs in a year, even if you include all other causes of death together. So if I think of a polytrauma patient resuscitation, this is what comes to my mind. Going towards the definition of polytrauma, polytrauma is defined as severe life or limb-threatening injuries with an injury severity score of more than 17. So briefly describing what an injury severity score is, you divide the entire body into 6 parts and each part is given a scoring from 1 to 5 based on the severity. So you take the 3 highest score, you square them and you sum them. I don't know how much of you have understood about it, but anyway, the number, based on it, you grade them to see the outcome and prognosis of the polytrauma. So whenever the number is more than 17, we say that the patient has polytrauma. And if the number is more than 25, there's a linear increase in mortality with the increase in the number also. So more than 75, these patients are not really salvageable. So basically, this is a visual aid for us to know which polytrauma patients, how the outcome and prognosis will be. This has already been dealt prior, but just to reinforce again, trimodal distribution of death pattern. So in this, what we see in patients with polytrauma is the early death, which is the first peak, happens within a few seconds. This is mainly because of the massive vascular injuries that take place. The second peak of death, which is occurring between 1st to 3rd hour, is basically because of all the problems that's related to airway breathing and circulation. So here's the role of golden hour and how we try to prevent it. Augustine sir has elaborately discussed this, so I'm not going into the details of this further. Next peak, the third peak comes after a few weeks. This is basically because of all the complications, sepsis, causing death in the patient. So coming towards the role of the anesthetist in management of polytrauma. Anesthetist plays a vital role, maybe from the beginning, from pre-hospital care to the patient reaching the emergency department, managing the analgesia there, maybe sedation required for few procedures, deciding which patient needs to be taken up for surgery, intra-op management, post-op ICU care, and then followed by maybe chronic pain management. So coming towards polytrauma pathophysiology, I'm basically talking about this is because it helps us to understand the management of these patients better, and also in the interest of all the UGs and PGs gathered here. So talking about pathophysiology, what exactly happens in a patient with polytrauma is, there is a concept of first hit and second hit. So when I say first hit, what happens is, these patients have massive soft tissue injuries, they have long bone fractures, all this leading to hypoperfusion and hypoxia. So this basically forms the first hit in these patients. The second hit is basically because of sepsis or interventional procedures, whatever is being done, or maybe they may present with compartment syndromes. So all this contribute towards the second hit. So whenever a patient has a first or second hit, they respond by producing inflammatory mediators. So I'm not going into details of which mediators are being released, but this syndrome is called as the systemic inflammatory response syndrome. So to counteract this, what the body does is, you have a compensatory anti-inflammatory response syndrome. So usually there's a balance between the two. When the imbalance occurs between the two, that's when we have organ dysfunction and organ failures. Coming to the next set of things that we really definitely need to know, that is how these patients present to us with. So they will have coagulopathy, hypothermia and metabolic acidosis, which is known as the lethal triad. This is probably being told the third time, but I'm saying it again because of its importance in the management. So when I say hypothermia, the patient has hypothermia. Why? It could be because of the ongoing bleeding. We are giving a lot of fluids which can further lead to hypothermia, a lot of exposure of the wound, and a lot of operative procedures where the third phase loss is increased. Along with this, there's also coagulopathy. The coagulopathy, before the concept was, it's basically a consumption coagulopathy. So here what happens is, nowadays it's called as the term used is trauma-induced coagulopathy, or the TIC. The TIC can be an early TIC or a late TIC. So what happens is, with all the hypoperfusion and hypoxia, there's injury to the endothelium which leads to a coagulation cascade, which later is halted because one of the above lethal triad, maybe hypothermia, coagulopathy, acidosis, all of them contribute to it. So there is a coagulation, anticoagulopathy developing with hypofibrinolysis. In the early TIC, what we see is that there's more of bleeding and hypocoagulation. And in late TIC, what we see is that there's more of thrombotic kind of complications. So when we talk about coagulopathy will further cause increased bleeding, and there is hypoperfusion. So what happens here? There is hypoperfusion to the organs, which leads to shift from aerobic to anaerobic mechanism. So anaerobic again increases lactic acidosis. Along with that, there are some ketone bodies being released and other acids, which leads to metabolic acidosis. Metabolic acidosis per se again reduces myocardial function, reduces oxygen delivery, again hypothermia. So this is like a vicious circle that keeps going if we don't stop it in between. So how do we prevent this? Now that we know this is the main problem in a patient with polytrauma, so what do we do to prevent this? So to prevent this, the first step is to stop the bleeding. And then to prevent coagulopathy, the role of tranexamic acid has already been discussed, but I'll talk about it later. Acidosis, to give blood-based resuscitation more. And then to prevent hypothermia, we use warming blankets, warm fluids, and maintain the OT temperature whenever the person comes for an operative procedure. So what is basically the aim of management in a patient with polytrauma? It's try to restore the patient back to pre-injury status if possible, life salvage, limb salvage, and salvage to the pre-total function if possible. So coming towards the polytrauma management, this has been explained a lot of times earlier. If I probably wake a student up tonight, they are just going to say golden hour ABCDE, that's for sure. But purpose of the CME being met, that's the whole idea of having the CME today. So being an anesthetist, it will be totally wrong on my part if I don't really comment on the ABCDE. So I'll just be sticking to the basics and the most important points from an anesthetist point of view. So golden hour already dealt with. Coming to primary survey, airway. So in airway, as an anesthetist, we look for the signs of airway obstruction. So we say, look, listen, feel. You see for any rib retractions, deformities, foreign bodies, listen to the hostess of voice, stridor. Feel for any tracheal deviation, crepitus. The main indication for intubation in a patient with polytrauma will be multiple like maxillofacial injuries along with the low GCS. So when we go ahead with the intubation, the main thing that we need to keep in mind is MILS, which has already been explained. That is the manual inline stabilization of spine, for which we need two people. One is the anesthetist who is intubating the patient, and we have another assistant who will be stabilizing the spine with two hands so that you can go ahead with the intubation. We also need to remember that unless it's clear that patient has no cervical injury, we take it as patient has cervical injury and go ahead with further management. Breathing, we look for if patient is spontaneous or not, rule out tension pneumothorax, flare chest, massive hemothorax or any of the above. Based on airway and breathing symptoms, the patient might need a cricothyroidotomy or intercostal drain. Sir has beautifully explained it prior, I'm not going into details of this. So when we come to circulation, again we'll have a rough look at the patient, externally inspect and see if there is any source of bleeding. So if there is any source of bleeding, you try to stop the bleeding there, put a local pressure. If the thorax is the source of bleeding, then you need X-rays or CTs to diagnose it and then go ahead with the ICD. Pelvic, you need to apply a pelvic binder and long bone fractures have already been dealt with. So coming to resuscitation, so bleeding is the main cause of death in patient with polytrauma. So the rule number one in management of polytrauma is stop bleeding. So whom do we resuscitate, where do we resuscitate, what do we resuscitate them with is the basic questions, which have already, all of them have been answered prior, but just to reinforce them. So we need to resuscitate patient with injury severity score of more than 17, as I've already told. Better done in a setup which is ready for resuscitation with all the emergency equipments and drugs. So what do we resuscitate them with? Initially, we definitely need to go for the crystalloids to wait for us to receive the blood. So blood being the ideal solution for resuscitation, but initially we'll start with the crystalloids. But whenever we are giving crystalloids, we need to make sure that we are warming them before giving them. And no aggressive fluid management with crystalloids. So with crystalloids, we are just targeting to maintain a suboptimal perfusion to prevent the side effects of hypoperfusion. So we're just going to maintain a suboptimal perfusion, but we are not trying to get the normal blood pressures back. So here the studies have shown that if you resuscitate a patient initially with more than 2 liters of fluid, the coagulopathy is presented in almost 40% of the patients. And if it is more than 3 liters, in almost 50% of the patients, and more than 4 liters, almost 70% of the patient land up in coagulopathy. So definitely no aggressive management with fluids initially. So coming to colloids, so can colloids be given? Colloids better avoided. Hydroxyethyl starch and gelatin have been used, but then the coagulopathy that's caused with gelatin can be reversed some amount with FFPs, but the one that's caused by HES is not reversible, so better avoided. So why am I saying this? Even the European guidelines say that the hypotonic saline can be used, but neither does it improve nor reduce the chances of survival. There have been few studies which have compared crystalloid versus colloids. So this is a Cochrane database review which says that providing colloids in these patients, it gives only moderate evidence that using starches as replacement fluid, it increases that the need of renal replacement therapy in a patient is more. But they have also told us that FFPs compared to crystalloids may make a little or make no difference in the management of the patient. when it comes to renal replacement therapy. So definitely FFPs can be given. So these are the few studies about fluid therapy in management of polytrauma. I'd just like to enlighten a few. That is, Anand et al. Have done a comparative study between the crystalloids and colloids, and they have shown that there is no statistical difference between the two. So there is no need to go in for a colloid when we can manage with the crystalloid initially, and we can avoid the coagulopathy that comes with it. There are a lot of contradicting evidence, so we really can't conclude depending on what fluids to use and how to use them. But we all know that blood is the ideal fluid to be used, and it can be given in the ratio of 1:1:1. That is, PRBCs to FFPs to platelets. The target hemoglobin being about 7 to 9, and cryoprecipitates are indicated if fibrinogen levels are less than 1.5 gram per dl. So what do we do if we don't really receive blood of the particular type, or if we are not able to match them earlier? We can go for O negative blood group. So coming towards tranexamic acid. So again, for the benefits of undergraduates who are going to write your entrance exams. So tranexamic acid, how does it help us? It's a lysine derivative. So what it does is, there's a lysine binding site on the plasminogen receptors. So it goes and binds in that and prevents the conversion to plasmin. So that's how it helps us. It also prevents the further release of fibrin degradation products. So coming to tranexamic acid, the study told us that early treatment with tranexamic acid, it improved the survival rate, and the death rate was reduced by 1/3 when given within 1 hour. So if it is given between 1 to 3 hours, then the death rate came down by about 1/5. And if it was given after 3 hours, there was no mortality benefit at all. It's already been dealt with earlier. Sir has already mentioned about the CRASH 2 trial. Talking about the CRASH 3 trial, it showed us that the immediate treatment improved survival by about 70% when it was when tranexamic acid was immediately given. And with every increase in 15 minutes, the survival came down by 15% until 3 hours. After 3 hours, again, it was of no use. So how do we give tranexamic acid? Sir has already told that 1 gram over 10 minutes, and then you give an infusion of another gram over 8 hours. So coming towards some of the emerging concepts in trauma resuscitation. So the new concept is damage control resuscitation. So what exactly is the damage in a patient who is a trauma victim? The amount of hemorrhage will only be known seeing the severity of the injury, the organs that have been injured, and if the patient is a fluid responder, partial responder, or a non-responder. So coming to the concept of damage control resuscitation, here what we follow is a permissive hypotension, hemostatic resuscitation, and damage control surgeries. So when I say permissive hypotension, here we are accepting a little lower normal levels of the systolic blood pressure, that is about 80 to 100. I'm not talking about traumatic brain injury patients here or pregnant patients. In a normal normotensive patient, what is recommended is about 80 to 100. So this maintains a suboptimal perfusion. So during this time, we have time to control the source of bleeding. So what happens if you really go on correcting the systolic blood pressure beyond, before controlling the source of bleeding, is that the bleeding will be further more, and also whatever clot has already formed, it can get dislodged. So this is called as the pop the clot phenomenon. So to prevent this, we do permissive hypotension. So the other thing is hemostatic resuscitation, which I've already told. Whenever possible, replace blood loss with blood loss. Along with this, we also need to correct hypothermia and coagulopathy and the other lethal triad that I've already told. And lot of transfusion can also cause hypocalcemia, which also needs to be corrected because some patients with hypocalcemia also present with hypotension. So after this, we also need to know about damage control surgeries. I'll be talking about that a little later. So coming towards the end points of resuscitation. So when do we stop resuscitating the patient? So obviously the normalization of vitals when the heart rates have reduced between 100, but this is a very arbitrary value and not really specific. When you see the vitals have been stabilized, you have achieved the systolic blood pressure of say 80 to 100 maybe. and normal saturation and a urine output of about 1 to 2 ml per kg. You can also use a mixed venous oxygen levels to see for a global perfusion, and near infrared spectroscopy, if you have heard about it, it gives you the value of skeletal tissue oxygen values. So you know what amount of systemic oxygen level is by seeing the NIRS, and it's also a non-invasive method of looking at it, and it can give you continuous values also. I'm just putting a picture here, but we are all Google friendly, so we can all Google it. So coming to the next parameter, that is the biochemical parameter, lactate plays a very important role here. So when I say lactate, why is lactate important? As I've already told, going back to the pathophysiology, so what's happening with the hypoperfusion, you're going from an aerobic to anaerobic mechanism by increasing the lactates that you're producing. So the lactate is a very good biochemical parameter to tell you how much of fluid needs to be given or how much amount of perfusion is there. So when I say lactate, is a normal only one value of lactate indicative of fluid resuscitation or hypovolemia? No. If you want to know the mortality of a patient, then lactate normalization or the repeated lactate levels are more important than a single level of lactate. So when you look at lactate normalization, so you have seen the lactate levels are more, it's more than 2 or 3, and you've started with fluid resuscitation. You need to repeat the lactate level to see is it getting normalized. So if the normalization takes place within 24 hours, we see the mortality is less than 10%. If the normalization takes more than like 48 hours, it's about 25%. And beyond 3 days, it can the mortality goes up to 70%. So disability and exposure has already been dealt with. Other investigations, we need to have a EBG to look at the acid status of the patient. And interleukin-6, one of the inflammatory, one of the important markers, which helps us quantify the secondary hit in the patient. It also is a direct predictor of mortality also. And X-rays, as Sir told, chest X-ray, pelvic X-ray and cervical spine X-rays, we need to restrict to these in the initial period. And coming to the next set of investigations, which are my favorite, that is focused assessment of sonography with trauma and IVC collapsibility. Talking about IVC collapsibility, it's one of the rapid bedside tests that we can do and totally non-invasive. So what we do here is, we use a curvilinear probe which is placed in the sub-xiphoid region, and we try to visualize the heart. We try to visualize where the IVC is coming out of the heart, probably about 2 centimeters from that point. You will see a hepatic vein joining the IVC. I think this is a little too much detail, but basically, you're seeing the movement of IVC along with respiration. That is, in the M mode, you're going to measure the IVC diameter, which is maximum and minimum. So you're calculating the collapsibility index using a formula, maximum diameter minus minimum divided by maximum into 100. This is something which we routinely do to see the fluid status of patient and the fluid responsiveness also. There are a lot of studies which show that patients with the collapsibility index of more than 40 to 50% are fluid responsive, and treating them with fluid is helpful for us. So other than this, the next one is focused assessment with sonography for trauma, which has already been explained prior. But just to reinforce again, 4 areas where we look at, that is the right upper quadrant, left upper quadrant, subxiphoid and the suprapubic area. So what are we doing basically? Again using a curvilinear probe, and we try to scan from the kidney upwards to look for any free fluid between the kidney and the liver in the right upper quadrant first. After that, followed by the left upper quadrant, where we see the perisplenic view to look for fluid between the spleen and the kidney. And then we go for a suprapubic view to look for any bladder injuries, and a subxiphoid view to look for any pericardial fluid. So FAST helps us because it's non-invasive, and it will help us with rapid decision making, especially in hemodynamically unstable patients where we don't have time to shift them for CT. So how do we go about FAST? So FAST, is it the final test that you need to do before you decide on the operative management? No, when I say that, CT is definitely the gold standard. But when we have a hemodynamically unstable patient, we can definitely go ahead with FAST. If FAST is positive, we definitely take them up for the surgery. But if it is negative, we need to repeat FAST again or go ahead with CT later. So it has a specificity about 95%, but sensitivity is only about 90%. So categorizing the patient later, so based on a patient's hemodynamic stability, if the patient is hemodynamically stable, what we suggest is we send the patient for CT, and depending on the CT report, then decide that the procedure needs to be taken up, or the method of anesthesia for them, could it be GA or under regional anesthesia. If the patient is hemodynamically unstable, we don't have enough time for this, so we go ahead with fast. With the fast, if it is positive, we directly go ahead with the operative procedures under general anesthesia with the rapid sequence induction. If in case fast is negative, as I've already told, we need to go ahead with CT later once they are stabilized. So then once we have stabilized the patient, we go ahead with secondary survey. Coming to role of anesthetist in sedation. So patient might require sedation for maybe small procedures which are done in the casualty like closed reductions or K-wire fixation, or even for diagnostic imaging. So whenever we are giving sedation, we should make sure it's given by a skilled trained person who is able to resuscitate the patient if required. And we have all the monitors and resuscitation equipments required before we give sedation. No single agent is ideal, and individualized agent is used as per the procedure and the status of the patient. Coming to my favorite topic, that is managing analgesia in these patients with the help of on-arrival block. So introducing the concept of on-arrival block, if you have heard me talk before, which is extremely unlikely, I always say that whenever possible, if you can treat pain, you should always treat pain. Pain is very subjective. Not everyone can tolerate pain, especially not me. So not every pain is treatable, but I always say 100% of the pain that can be treated should be treated. So going ahead with this, on-arrival blocks. So what exactly is on-arrival block? So when we receive a patient of polytrauma, they have multiple injuries. So because of these injuries, there's a lot of stress response, and that again, further deteriorates the patient. So giving a peripheral nerve block for the specific injury on arrival of the patient to the emergency department. That is, as soon as you stabilize the patient, giving a block is called as the on-arrival block. So where is it done? Usually done in the emergency department. But whenever we are doing it, we should make sure that you have all the equipments required for resuscitation. So what are the equipments that we need to give an on-arrival block? Extremely minimal, just an ultrasound and the drug and needle. So how do we give a block? Before we give a block, we need to make sure that we have taken consent of the patient and we have applied all the monitors and we are using the universal precautions. But also while giving a block, we need to know that block is not the priority, always the primary survey. Only after the primary survey, pain management comes into picture. We should always be aware of the associated injuries and also take the universal precautions. So this image is of me giving a block when I was working in Ganga Hospital. So this was a 16-year-old male who presented to us with extreme pain following a traumatic amputation of the arm. So following a block, is it only management of analgesia in the patient? Definitely not. Definitely giving a block reduces the pain and decreases the stress response, but also with it, regional anesthesia per se reduces some amount of bleeding. And also you can apply tourniquets and examine the patient better. So there are added advantages to just analgesia when it comes to on-arrival block. So this is one of the examples where on the left you see the X-ray of a patient who had, this was the X-ray prior on-arrival block, and the next one is the X-ray where you can evaluate the patient better, that is post giving a block. So what is the other role of regional anesthesia when it comes to on-arrival blocks is that, especially in patients whoever is going to undergo a reimplantation. So in these patients, having a proper blood flow and maintaining or avoiding vasospasm is extremely important. So whenever you give a block, there's a sympathetic blockade which leads to decrease in the vasospasm and allows maximum vasodilation. So along with this, even the tendency to go into hypocoagulability, okay, forget it. So and thrombotic events also comes down. So along with this, even the circulating catecholamines come down, and the patient is not able to move the hands. So better muscle relaxation also. So another set of patients who benefit from on-arrival blocks are patients with rib fractures. So what happens when you have a rib fracture is that because of so much of pain, you're not able to cough well or remove the secretions, which leads to pneumonia and atelectasis with a course of time. So to prevent this, on-arrival blocks have been extremely helpful, and these have been shown in a lot of studies. I'm not going to go into details of this. I can see few UGs peeping out to look if food is already there, and I see few yawns here and there. So I'm not going to bore you guys with all the evidence and data. So moving ahead, so just few important points. Can we address the grey areas? So can a block be given in a patient with antiplatelets? Definitely yes. With the advent of ultrasound, we are able to visualize the tip of your needle. So you know where exactly you are. So all that you have to do is try to avoid a vascular puncture. And can on-arrival blocks be given in proximal tibial fractures? You can give them. Before they used to tell that it's contraindicated because the patient can develop a compartment syndrome, and you totally miss diagnosing a compartment syndrome because the patient is not complaining of pain. This is totally not true. The evidence shows that giving a block with a low volume of the anesthetic, with a low sensory concentration, a breakthrough pain from this is a better indicator of compartment syndrome than with no block itself. And can block be given in a patient with pre-existing nerve injuries? Yes, you just have to document what the pre-existing injury was. And one more interesting question is, can blocks be given bilaterally if they have bilateral fractures? Can be given, but which kind of block you're giving needs to be dealt with. So one side you can definitely give a above clavicle block, and the other side should definitely be below clavicle to reduce the involvement of a phrenic nerve. So coming to last few slides of my presentation, makes you people happy there in the back. But anyways, going towards damage control surgery. So what exactly is damage control surgery? So all these patients with polytrauma, they don't really have the physiological backup that they need to undergo a major surgery. So what we do is, we do only the life and limb saving procedures at that point of time, and then you shift the patient to physiologically restore them, and then you take them back for a definitive procedure. So the timing of surgery needs to be decided by both the surgeon and the anesthetist. So initially on day 1, we just do life and limb saving procedures. On day 2, we can definitely go for a relook and reassess what needs to be done. Then we have a window of opportunity between day 5 to 10 when definitive surgeries can be done. Patient goes into immunosuppression post that between the second week. So that is a time that we need to really avoid the surgeries. And if you have any reconstructive surgeries that you need to do, you can go for it beyond 3 weeks. So how do we anesthetize a patient? Sorry for that. How do we anesthetize a patient for emergency procedure? We need to optimize the patient, and we have a lot of anesthetic consideration, like it's emergency procedure. It can be a full stomach patient. The patient can be intoxicated. We won't really have details of their comorbidities or what they are associated with. When I say preparing the OR, we need to keep the OR ready with fluid warmers, body warmers, the difficult airway cart, and all the emergency drugs. When I talk about the plan of anesthesia, I don't really know how much you'll understand when I say this, but general anesthesia or regional anesthesia per se depends on the status of their patient, their hemodynamic stability, their airway, and what procedure they are going to undergo. But usually when a polytrauma patient comes with hemodynamic instability or a full stomach, we go for general anesthesia with rapid sequence induction. Just a few terms which again is important. What I mean by rapid sequence induction is, there's a chance that these full stomach patients will aspirate. So what we do here, we give a cricoid pressure. If you can see what the second person is doing there, he's giving a cricoid pressure. So you rapidly induce the patient, that is, you initially pre-oxygenate them, following which you give induction agent. Again, depending on the procedure and the patient status, you decide which agents to give. Whatever you're giving, you give in a very titrated way so that you don't really cause hypotension. following which you give a neuromuscular blockade, and immediately you try to intubate the patient, and once the cuff is inflated and you're sure where your tube is, only after you're sure that you have placed the tube in the trachea, then only the assistant removes the cricoid pressure. So this is basically done just to prevent aspiration in this patient. So my discussion with trauma and anesthesia will be incomplete if I don't talk about difficult airway, because definitely these patients are subjects of difficult airway, a nightmare for the anesthetist. So we have the difficult airway guidelines here. So initially we, pre-oxygenate the patient and go ahead with the first step, that is laryngoscopy. If you have failed it and if you're not able to, place the tube in the trachea, what you do next is you go for a supraglottic airway device. A supraglottic airway device is basically a device which has a tube and a mask at the end of it. I should have put a picture, but anyways, so the mask basically seals right above your larynx. So what it does is it helps you provide oxygenate the patient without actually being inside the trachea. So it's like a mask which is covering from outside and you're trying to oxygenate through that. So this we basically do when we are not able to intubate the patient. So the second step is you go ahead with the supraglottic airway. So if in case you can do the procedure just with the supraglottic airway, you go ahead with that. If you want to intubate a patient, you try to intubate a patient through this airway, because we have some of the airways which facilitates that. If you're not able to do that, then you can just wake up the patient. The next idea, if you want to, if you're not even able to place a SAD, is that you go ahead again with bag and mask ventilation. If you're not able to do that, then you need a front of neck access as the final one. So some of the advantages of regional and general, which I've already told through the course of my talk, that is, once you get regional, there is reduced bleeding, there's no pain, better post-op pain management, and also the patient cooperates better. You can see his mental status throughout the procedure, and also it prevents all the vasospasm, so it's better. So when we come to general anesthesia, definitely anesthetist's favorite is to secure the airway. You always want to be sure of the airway. So when it comes to that, general anesthesia is beneficial. Also, its speed of onset is more, like regional will take some time to be established. We are faster with the GA. And no matter what the duration of procedure is or how many procedures or which area of the body is, we can address with the general anesthesia. So criteria for extubation a little beyond the scope of the discussion, so I'm not going into that. And then role of anesthetist in ICU, we basically stick to trauma specifics. That is, again, you do a tertiary survey so that you make sure you haven't really missed anything prior. You reassess all the radio imaging and see if you have missed anything before this. You make sure traumatic brain injury protocols are being followed. The cervical spine has been cleared. Also, simultaneously make sure infection control is there with hand hygiene and taking care of all the lines and catheters. And some ventilatory protocols to make sure they don't land up in ventilator-associated pneumonia. And also always assess the patient every single day to make sure if the patient is ready to be weaned out of the ventilator. So the last slide, coming towards the management of chronic pain. Prevention of chronic pain is much better than managing them. So whenever possible, we must try to treat acute pain. The patient can still present to us with some complex regional pain syndromes or phantom limb pain or persistent post-surgical pain. We call it a persistent post-surgical pain when the patient presents with pain even after 2 months post-surgery. This is because of some of the inflammatory procedures or neurogenic inflammation. The mechanism is not well known. But whatever the cause of chronic pain may be, usually treated with anti-neuropathic drugs like gabapentin. Some amount of IV ketamine is also helpful. Opioids can be given, but we need to be aware that they can go into opioid dependence. So when it comes to phantom limb pain, usual MCQ questions, mirror therapy is usually recommended nowadays. So that's it. Coming towards the end of my presentation, that's how anesthetist looks post-trauma call. So thank you. I hope I've not bored you all much.
Thank you, madam, for this nice lecture. You have covered every means all the aspects, especially newer trends also, like ultrasound usage in inferior vein collapsibility, just to know whether it is hemodynamically stable or unstable. It is a new this one, I think all newer graduates, they have a knowledge of ultrasound at present. And also, like you have discussed about on-arrival block, I think it is very common in Ganga Hospital.
Yeah.
Those who have done a fellowship in Ganga Hospital, always they will tell they are doing that our on-arrival blocks actually. It will be very useful also. These are new techniques, and as our main role is the airway control, like tracheal intubation. I present anesthesia, present interns, all interns have a posting in anesthesia for 15 days. I will see that all the anesthetists, those who are posted in my OT, they will be doing one intubation, because tomorrow if they are posted in emergency room or if they see any road traffic accident, if they are trained in Kanachur for a 15 days, they should be boldly to intubate a patient. That is my criteria. Still some anesthetist interns are escaping. They will be sitting there here. But I will make them who is posted in surgery. If there is a general anesthesia case is there, I will see that those people at least take the laryngoscope or at least intubate. I think some people are interested, some people are not interested. I cannot force those who are not interested. Anyway, nice. You have discussed nicely role of anesthetist in the polytrauma.
Thank you, Doctor, for that exhaustive presentation. The other important aspect that we are called upon is massive blood loss. So many times in polytrauma, we face patients with massive blood loss. Massive blood loss is, for us, the most relevant definition is 50% of blood lost within the first 3 hours of trauma. So it's important to have a well-equipped blood bank, and we should have a protocol in the blood bank to trigger a massive transfusion protocol, so that we can get uninterrupted packed cells, FFPs, and plasma blood products. So having said that, in countries where expense is not a problem, there are drugs like 5-mil concentrate and activated factor 7, which help in arresting bleeds. So the goal is debatable, but for us, it's prohibitively expensive. Thank you.
Thank you, sir.
The other thing is role of tranexamic acid. So this tranexamic acid, I was involved when the phase 1 and phase 2 and phase 3. After that, they made it's compulsory in all trauma patients. Till then, it was not there. Because involved when I was in UK in phase 3 trial, that it's a role of tranexamic acid in acute trauma patients.
I think today's all the speakers spoke about tranexamic acid.
Yeah, it's a compulsory, and everybody should know where to use and when to use, particularly in acute trauma patients.
So also, not in the trauma, I have seen obstetrician gynecology after cesarean section. Nowadays, all obstetricians are using tranexamic acid. Like we are on this one, no? We are asked to give oxytocin, methergine. Now they are asking us to give to tranexamic acid also. Like all it is a new trend now. I mean, they are telling the incidence of bleeding is this. Yeah. Any questions from the audience actually? Role of anesthetist in polytrauma. Actually, I think role of anesthesia is very important in anesthesiology in polytrauma. Surgeons plus anesthetist is there.
The anesthetists are the leader in the trauma team.
We always consider a little high about ourselves, sir. Whenever it comes to anesthesia, the last video that Vikram sir played, I think the goat which was going ahead is always anesthetist.
Yes, sir. But we are leaders, but the appreciation usually won't be not. We are not. No, that's always surgeon.
No, that depends. That depends on the outcome.
No, if you go for any impressive photography, anything, anesthetist should be last like that. First will be the surgeon. But nowadays it is changing, sir.
Thank you, ma'am, for your enthusiastic talk. I request the moderators to present the momentum.
to Dr. Vincent sir.
Vincent sir and me are classmates.
High school days, sir.
High school, college, Karna. He born in the college, Karna. In fact, Devdas Shetty was my first graduate. I was doing MBBS. Sir was MS in my school. Yeah.
I would like to request Dr. Lancet Lago, Assistant Professor of General Surgery, Associate Professor of General Surgery, KSAT Medical Academy, to hand over the memento to Dr. Samuelson.
Now the session is for lunch break.
In 5 minutes, lunch will be ready. In 5 minutes, the lunch will be ready and we'll be having a break for 1 hour.
ಹಲೋ ಸರ್ ಒಂದು ಕ್ಯಾಮರಾದು ದಾದಾ എന്നെ ആക്കിയിട്ട് ഫോൺ എടുക്കാൻ ഫോട്ടോ എടുക്കാൻ നീ ആക്കിയിട്ട് പോയിട്ട് വന്നിട്ടില്ല രണ്ട് ഫോട്ടോ എടുക്കടാ അവരെ കളിക്കലൊക്കെ ഫുള്ള് എത്ര സർട്ടിഫിക്കറ്റ് എന്നെ ഉണ്ട് പറഞ്ഞിട്ട് വെച്ചത് അപ്ഡേറ്റ് അവരെ സർട്ടിഫിക്കറ്റ് ഫോട്ടോ എടുക്കാൻ കുടുങ്ങായിട്ട് ചെന്നിട്ട് yes, yes.
Mr. Kalyan, ಒಬ್ಬ ನಂಬರ್ ಸಿಗ್ತಾ ಇದೆ ಕಾಲ್ ಮಾಡಿ
पकड़ो भाई अपना डालो मुझे काम How are you? I'm fine. How are you? I didn't meet you after that day. You don't come right away? No, not really. Few days same time. Movie is releasing tonight. ನೋಡಿರ್ತೀಯ ಎಷ್ಟೊತ್ತಿಗೆ ನೋಡೋದೆಲ್ಲ ಎಡಿಟಿಂಗ್ he has to know now we say I still find mistakes. Yes, it is there's no end to it. I think he calls you and he calls you say he does the mistake itself you will see. But he doesn't tell the mistake itself. Yes, he fixes up the but there's that we are kind of bad. You want another person totally opposite. When you write you complete make sure you see it backwards. You start reading it backwards. So that it doesn't make sense to you. It should be like somebody random should challenge to bring it under whatever time. When you shot it into some 5 years. Then we brought it down to 3.5 years. Then 3:10. We wanted it under 3. So we made it 3:59 and 2:59. Still it was like everybody's roles will be going. I think I stopped saying that and I started saying I'm only a guest of here. That is like saying anything more than that was fine. I'm director's fine. So now it is weeks especially with Telegram. The whole movie will come up with before release. So scarcely nobody would be able to do anything. I'm just there on the mode. Yeah. But it's a big deal now. The thing is with theatres. Because many movies are crashing on 39. Seriously, any big release? It's not about merit, it's about the whole. What's the name? Just go and see. It doesn't matter if someone can do much to have the courage to make it after this. You will say it took me exactly 3 minutes. Now what is happening is that movie was made by this film. It was a memo. Race 3. They made that but only for name's sake. When you open the door, no, I'm no more directing someone. The interference is so much in there. So whenever the interference is good, Still, I was best to accept it and say no, because I'm getting all from doing your one chance you got it. What is that's the impact I said. It looks like what's that? Performance. So, may postpone it for a week. I mean, if he postpone as in maximum 1 week. Now the thing is another film broadcasting. All this broadcasting. This is satellite is huge. That is how it is captured until release. So other things are scary. Somebody gets don't want to go to theater. Just hardcore movie goers, they want to. Yeah. The problem is there's so much entertainment. Hardcore movie goers must reduce, I feel. I mean, not that I'm in that field, much rather, that's why Raghu is getting proper association.
Yeah, moderator level. All the moderator. Oh, please come, please come. Yeah.
Please be seated.
Check on. Yeah.
Next topic for our next session will be approach to head injury patient. And to moderate this session, I would like to welcome Dr. Deepak sir, neurosurgeon from Srinivas Institute of Medical Sciences.
Now I would like to introduce our speaker, the dynamic, brilliant and extraordinary Dr. Kevin Lobo. Is an associate professor in the Department of Neurosurgery at Father Mullah Medical College. He graduated from Rajiv Gandhi University, specialized in neurosurgery from Manipal University. His interests are brain and spine trauma and pediatric neurosurgery. He is the president-elect of Rotary Club of Mangalore Midtown. He is also an active member in American Association of Neurological Surgery, Indian Society of Pediatric Neurosurgery, International Society of Pediatric Neurosurgery, and Neurological Society of India. I welcome you, sir.
Thank you. Am I audible? Thank you for that generous introduction. Good afternoon to one and all. Firstly, I would like to thank the organizers for giving me the opportunity to speak on this topic for the day. Secondly, I'd like to appreciate the presence of my seniors over here. I think without their effort in building me, I wouldn't be standing before you here today. A compliment to the organizers. I think we should all appreciate it. We had a very good lunch. Yes, I know. Thank you. So after lunch, going and watching a matinee show is a dream come true, at least now. Okay, and consider this to be a matinee show. Okay, so if you see, when you watch a movie, even after a week or after a month also, you will still remember the chronological order of every scene in the movie. But that doesn't happen when you think of it as a lecture, because your brain is trying to bite a lot of information and get fatigued within 10 minutes, and after 15 minutes, okay. So welcome to my movie for today. Now before we start, we just go to a little bit of basics. The objectives here are very simple. How to approach a patient with head injury, a detailed examination, the history to be taken, investigations which are relevant, and then definitive treatment. So we will come to the scene 1. Always our movies have a happy family in the beginning. Okay, so there is a happy family. Everything goes well till this guy meets with an accident. That's the accident. Now a good Samaritan calls the ambulance, and the ambulance comes immediately, picks up the victim and rushes him to the hospital for him to be bandaged. Okay? Then the doctor enters the scene. So we have the doctor there. He examines the patient in detail and he says an operation is required. Now, there's a lot of tension, there's a lot of commotion, people start crying, wailing, but then the operation has to be done.
So the guy is into the operation theatre and the operation is going on for the next 3 to 4 hours. Again reappears the doctor. Good news, it's been a successful procedure. There has been no hiccups. But the patient has been bandaged all throughout and it will take some days for him to recover. So when he recovers, the bandages are slowly coming out. The surgeon is slowly pulling out the bandage and look who appears. Wow. Now this is what is fed to us. And even further, now this guy, after he's coming out, he has this problem. The question is, was it a plot of the director just to change the actor, or does this really happen in real life? I think we'll come to know as we go further in our journey today. So, managing trauma. I have divided this into 3 parts. The first part being at the site of accident, the second part being during transit, and the third one being at the hospital. Most of us are abreast with the hospital management because we are regularly seeing such things. But what happens before the patient comes is also equally important. The buzzword, don't get scared. Whatever you are doing best for your victim, best for your patient. Anything more than this could not have been done at that particular point. So at the site, first thing is you check out for your safety. If you're riding or if you're driving, try to park at a safe destination and go down to help the victims. Make sure to call for help. We are all not Amitabh Bachchans of this day, so one man show doesn't work. Call for help, delegate some work to them. You can tell one person to call the police and the ambulance, the other person to help the rest of the traffic to move around, and maybe you yourself can go to help and survey what's happening at the site. Make sure that you see for any fuel spillages or any inflammatory objects which could cause more trauma or more problems to the site. The last thing is to survey the injured. Now when you survey these people, you have 2 types of victims at the site. One is the guy who cries, calls for attention, tells everybody that he is having a lot of pain and he is going through a very bad time in life. And the other person who is silently sleeping there. Okay, now this is the person we have to be very, very serious about, because that is the person calling for your help. That is the person who needs your help, and timely intervention can help that person. So what do we do? The first thing is start off with basic life support exercise. Put the patient supine. Try to remove whatever debris are there in the mouth so that the airway is patent. Put him on a firm board and strap him out so that if at all there is any spinal injuries, it could be overtaken. This is a regular spinal board which is seen in most of our ambulances around the city. It also has a head stabilization part. Now, why am I stressing on this point? These are the 2 small studies which are put up here. One is from our own India, KM Hospital, Bombay, and the other is from Ghana. And both the investigators have come to the point that it is very important to make sure that the victim gets a good pre-hospital care, transported well, which definitely reduces mortality and definitely reduces the severity of injury. So all of us, even after an operation, even after an accident, we'd like to walk and do our own work. So during transit, these are the few points we should plan to see during transit. First thing is the patent airway. Make sure that it has an oxygen cylinder so that you can give oxygen at 6 liters per minute. The strapping has to be done adequately. It should not be like, for example, our road. I think regularly many of us come to this place. One bump and the patient is out of his spine board. That's not going to work out. Okay. And communication to the hospital where the victim is intended to be ferried to, so that they too would get ready. They too would get ready with their faculty to act as soon as possible. At the hospital, very simple. The patient is transported to the trauma room on the spine board. We are not going to remove the patient off the spine board unless evaluated. Brief history as to when and where the RTA was occurred. LOC is very important. LOC is loss of consciousness, and anything more than 30 minutes is significant. It has to be noted down. The other histories which can be taken are seizures, vomiting, and limb weakness. The steps of assessment. Very simple. I think all of us know because we've seen trauma from the time we are interns. A, B, C, D, E, F. Now, A is airway. It is also associated with cervical spine assessment. So, a brief palpation along the neck or a X-ray of the C-spine can give us a picture whether there is a trauma or the vertebrae are well aligned. Breathing is one important thing, especially in head injury patients. They could come with spells of apnea and hyperventilation. Again, a spell of apnea, again hyperventilation. This is abnormal breathing. And if the patient is having difficulty in breathing, has to be intubated and ventilated. Circulation, blood pressure as well as heart rate. As I put in the previous slide, the blood pressure should be at least a systolic blood pressure of more than 90 millimeters of mercury and a heart rate of more than 60. It helps to well perfuse the brain. So we're going to save the brain by having normal vitals. Now, disability is a very big chapter over here. The first thing that we have to see in neurological disability is the GCS, Glasgow Coma Scale. The next point is shine the torch into the eyes of the victim. If the pupils are reacting well, chances of a major head injury is much, much less. If there was a major head injury and there's a lot of swelling, the third nerve is the first nerve to get involved. Third nerve supplies our pupils and our pupil would be dilated. The other thing is to check for the movement of the limbs. Give the patient a little bit of stimulus, a little bit of pain. If he starts moving both his limbs, obviously there is no deficit, there is no disability. And if not, obviously there could be hemiparesis, which is pointing out to a neurological injury. Now, what if he is moving both his hands but not moving his legs? There is still a neurological injury, and the neurological injury from the brain comes down to the spine. There could be some level of the spine which is involved. The last two is evaluation of loss of consciousness. Now, there are many reasons for evaluation of loss of consciousness. The first and most common thing is inebriation. People have a lot of substance abuse. They are under influence of certain substances. That also could cause loss of consciousness. Hypoglycemia. Hypoglycemia is quite a regular feature where patients who have loss of consciousness have a very low glucose levels. Hypoxia itself can cause loss of consciousness. If there are any wounds around the place, the wounds have to be taken care either by dressings or regular sutures. Fractures, very important. It causes one thing, loss of blood loss. Second thing, instability in the patient. So either fractures of the skull or fractures of the long bones have to be evaluated either with a CT scan or regular X-rays. A small poll now, just to keep the tempo going on. Okay, so we'll revisit this poll at the end of the movie so that we'll know what exactly we are talking about. So any injury to the head is fatal. You can keep the answers in your mind. You need not. It's for self-assessment. That's it. So yes, no, don't know. Treatment of head injury is useless. Many people have this concept that anyway they're going to die, so no point. Useful. It may help the quality of life. There's a third point to say we don't know. So all head injuries result in memory loss. True, false, occasionally. All head injuries must undergo a CT scan. Yes, definitely. No, not necessarily. Don't know. Now, if they survive, if head injury patients survive, it's by God's grace, definitely it could be God's grace, it has to be God's grace. By human intervention, pure luck. So how do we divide head injuries? So head injuries are divided into three types. Scalp injuries, skull bone injuries, and the big daddy brain injuries. So we'll take the small guys first and then come to the big daddy a little later. So scalp injuries are very simple. We have abrasions, lacerations, avulsions, and subclavian hematomas. So an abrasion is a simple type of an injury. Nothing much to be done. We just give topical antibiotic ointment and that should surface with the treatment. Laceration. Now what is a laceration? Laceration is the cut-like injury, but it is not done by a sharp instrument. It is done by a blunt instrument which hits the skin in that intensity that the skin splits up and ends up with a laceration. So it's got two narrowed edges and a belly. The most important thing is the force of the injury could go through the skull into the brain. So this requires a thorough wash to debride the wound, to remove off any foreign body or any clot over there, and after attaining hemostasis, a two-layer suturing. The first inner layer done with an absorbable vicral suture over the galea aponeurotica, and the outer one done with nylon, which is the skin. Oral medications are more than enough for this type of injury. The AAA therapy, antibiotic to avoid infections, analgesic for pain, and antacids. Why antacids over here? It's a rule that every trauma causes increased secretion of gastric contents. So increased secretion is going to have more acidity, and this acid could cause duodenal ulcers. These duodenal ulcers in a head injury patient are called Cushing's ulcers. So you will see blood coming out through the Ryle tube on the following day. So antacids form a very important modality of treatment in head injuries. Avulsions. Now this is a little more serious injury where a part of the skin is pulled out. This requires an admission and observation at least for 24 to 48 hours. The procedure has to be done in the operation theatre where it is thoroughly debrided, and while closure, a drain is advised to be put, because one thing, there could be a collection, there could be a hematoma, which we can see it at a later date. Last one is the acute subacute hematoma. I call it cute because it doesn't cause any problem to the patient, doesn't cause any problem to the doctor. It says hello to you and goes off all by itself after 15 days. The only problem this can form is it may get infected, and this can be managed with a simple incision and drainage and followed by antibiotics. The next little graver injury is the skull bone fractures. Now here we have linear or depressed fractures. I'll explain to you later. Simple, where the skin over the fracture is intact, and compound, where the skin over the fracture is opened up, and calvarial, that's the top part of the skull, and base of skull fractures. Now if you see in this picture, this is a simple fracture where we have just a small line going across the undisplayed fragments of bone. They're not displaced, they're all intact. Many a times they are quite simple and doesn't cause any problems. And then we have the little graver brother, the depressed fracture. Now when do you call this a depressed fracture? When the outer table of the fractured segment is in line with the inner table of the unfractured segment, it is called a depressed fracture, and they usually associated with the intradural hematoma. Now these are the dangerous guys, and the hematoma has a chance of increasing in these patients. This is the skull base. Now the skull base is divided into three parts. We doctors like to keep on classifying things and making things more complex. Anyway, this is the greater wing of sphenoid. So anything in front of the greater wing of sphenoid is called the anterocranial fossa. It has very few structures, in fact no structures at all. The part between the greater wing of sphenoid and the petrous bone over here is called the middle cranial fossa. Now this part of bone has a lot of structures. It has the internal carotid artery, it has quite a few nerves passing through this, and this part of the skull is called the posterior cranial fossa. Now the most important fracture over here I would like to stress is the middle cranial fossa fractures. Now since our facial nerve runs through this bone, a longitudinal fracture would not cause much of a damage, maybe just cause a little bit of facial palsy, but a transverse fracture would lead to a transection of the nerve, which could be a permanent damage to the facial nerve. So what are the clinical features? First one, nose bleed or ear bleed. Now this bleed could be associated along with CSF leak. There is something called a target sign or a halo sign through which we can make out that there is a CSF leak, raccoon eyes and battle sign. So this is how a nosebleed or a ear bleed would be seen. Target sign, I would like to show you a target. This is how a target is seen, but target sign doesn't look just like this. It is usually seen on the patient's garment, on the bed sheet or the pillow or whatever he's using. And there is a central blob of blood surrounded by a halo of CSF. This goes in favor of a CSF leak with the patient. The third one is the raccoon eyes. Yeah, here we have Kareena Kapoor Khan. She's actually a Halloween makeup look that she had, but she's trying to here also put into us the eye part of it, which shows that there is some discoloration in any head injury. Now, this is how a raccoon is. A raccoon is a nice small animal which has darkened eyes, and in a patient, it will look like this. And this signifies an anterior cranial fossa fracture through which blood seeps down into our eyelids and it gets discolored to form a darkish hue. Now what happens if this similar thing happens in the middle cranial fossa? I was just saying middle cranial fossa is very dangerous. There it would seep into the subcutaneous tissue behind the ear, and this would look as battle sign. Most of our books tell us that this is usually not seen in colored people. I mean, we are all colored is what they say. But if you take a little detailed look, we definitely can appreciate this sign even in our people. Management, simple. First, we have to investigate the patient, complete blood count, a renal function test, a liver function test. Coagulation profile is very important. We should know if the patient is having bleeding diathesis or any of those ailments. Screening tests, you can also add a COVID-19 RT-PCR over there. Radiological investigation, very important, is the CT cuts or the bone cuts of the brain. Now, if you can see this is typical of a depressed fracture. You can see the outer table in line with the inner table. And this is a linear undisplaced fracture of the posterior cranial fossa. This is a 3D picture. I mean, the latest CT scanners have this type of 3D pictures. There's a small story behind this thing. Actually, this is a patient who came to us. He's a 11-year-old boy who was a wicket keeper. And the batsman tried to do skipper Dhoni's helicopter shot, and the tip of the bat went and hit him right on his forehead. That's why the indentation over there. Anyway, this patient was managed with surgical elevation of the depressed fracture. Now the treatment is very simple. We have to keep the patient in the ICU for observation for 24 hours. As I said, such fractures can lead to intracranial hematomas. NPO, whenever we keep NPO, IV fluids have to be put on. Oxygen mask is mandatory. Patient is kept flat in bed. In case the patient has a CSF leak, then CSF production, to reduce the CSF production, we have drugs like acetazolamide, Diamox, this tablet Diamox, 250 mg TID is prescribed. Antibiotics, like how CSF comes down, infection also can go up our highway into the brain. Very important antibiotics. It has to be given in meningitic doses. And lastly is the most simple thing, it's a surgical reduction of the depressed fracture. Now coming to the main guy. So the brain injuries, or these are the injuries which cause raised ICP. Now I have divided it into two basic differences. One is diffuse injury and one is focal injuries. The diffuse injury is concussion and diffuse axonal injury. They are two ends of the severity spectrum. Concussion injury is a very simple injury. It comes in the least traumatic injury. Usually the patients have a loss of consciousness for about 2 to 5 minutes. They have a little bit of headache and they usually recover over a 24-hour time. The CT scan is absolutely normal. A repeat CT scan also does not show anything, and the patients get back to their regular life as before. In comparison, diffuse axonal injury is a very serious injury. Patients have prolonged loss of consciousness. They may not come back to consciousness, and even if they come back to consciousness, they may not come back to the complete abilities. CT scan may appear to be normal, or there may be edema, and the MRI scan will show multiple small hemorrhagic contusions over the cerebrum, corpus callosum, and brainstem. So these are the basic clinical features. Loss of consciousness, all of us will know. Seizures, hemiparesis, third nerve palsy, which will manifest like pupillary dilatation. Sixth nerve palsy, where there is deviation of the eye outwards. Abnormal breathing patterns, and bradycardia and hypertension. These two things form the Cushing's reflex. So after the intermission, we get back to the movie. Now, in this action movie, we have a lot of characters over here, but the most important thing is who is the villain. Now, the villain here is raised intracranial pressure. Just to touch on basic physiology, the intracranial pressure in a normal human being is about 5 to 15 millimeters of mercury and about 6 to 18 centimeters of water. It's made up of 3 components: brain, blood, and CSF, nothing else. To exactly explain what exactly happens, we have this Monroe-Kennelly doctrine, which says the sum total volume of brain, CSF, and intracranial blood is always constant, and it is equal to the volume of our cranial vault. Now, this is normalcy. Now, this is where a small mass, it could be a hematoma, it could be a tumor, it could be anything which is trying to take the space of the rest of the three components, which ends up. But here there is a compensated state where the CSF is poured out, the venous blood is poured out, and therefore the blood is trying to maintain its pressure. Now what happens if the mass increases exponentially? The CSF poured out, so there is no nutrition to the brain. The blood is poured out, so there is no circulation to the brain. So obviously the brain is going to end up with injury. Now when it comes to injury, there are two types of injuries. There is a primary injury and a secondary injury. The primary injury occurs at the site of accident. None of us can do anything. Something has entered his brain, there's a shrapnel in his brain, nothing can be done. Okay, but what we can do is try to reduce the secondary causes of injury. And what are the secondary causes of injury? It could be edema, it could be hypoxia, it could be hypoglycemia. These are all what we should intervene and try to reduce that such that the brain heals out well. So where in trauma does intracranial pressure increase? So first thing is if there is increased blood volume in the form of a clot. Second thing is if there is increased brain volume in the form of edema. So coming down to the focal head injuries, extradural hematoma is a very common presentation. It is a neurological emergency. It usually happens due to the ruptured middle meningeal artery. Middle meningeal artery is a branch of the external carotid artery. Rarely because of a venous origin. The hematoma lies between the skull and the dura. It respects the suture lines and is usually associated with a skull fracture. On the contrary, a subdural hematoma. The hematoma is below the dura. Venous damage. So venous damage, where are the veins? The veins are on the brain itself. So the brain parenchyma also can be damaged. Does not respect suture lines, and it has three types. It is an acute, subacute and chronic. The acute one is the killer. Now this is the pictorial representation where the green line over here shows represents the dura. Anything external to the dura is the extradural hematoma. Anything internal to the dura is the subdural hematoma. So how the third component is contusion. Now this is an injury to the brain itself, the brain parenchyma itself, where the pia and the arachnoid layers are intact. It is usually localized to one lobe of the brain, and this is like a crouching tiger. It can increase in size over a period of 24 hours. Management now. Assessment, investigations, and then we go for definitive treatment. Now, how do we assess? The assessment is very simple. Glasgow Coma Scale, open your Google search, check out Glasgow Coma Scale, comes on your screen. What is on the patient? You score the patient. Till 1974, there was no Glasgow Coma Scale. It was in 1974 that Professors Brian Jenney and Professor Teasdale from the University of Glasgow published this paper, and it was taken well with the trauma caregivers, and GCS became the language of traumatologists across the world. The next is investigations. Complete hemogram, renal function test, liver function test, coagulation profile, screening test. The radiological investigations involves first a CT brain, ultrasound abdomen to see for any blunt abdominal trauma, and X-rays to see for any long bone fractures. Now, when do we get a CT brain? There are certain indications. I put it in the alphabetical order. Loss of consciousness of more than 30 minutes, a GCS of below 13, any GCS which drops down by 2 levels. Say if the patient comes at GCS 15 and it goes down to GCS 13, indicated. Elderly people above the age of 65, if the patient are on antiplatelet or anticoagulant drugs, the chances of bleeding are more, hence the CT scan. And if the patient is having focal neurological symptoms. Now this is how on a CT scan EDH would be seen. It's a biconvex hyperintense shadow. That is the blood component over here. This is how subdural hematoma is seen. It is a concavo-convex shadow, and it does not respect suture line. There is a bit of confusion over here. This is the damage of the brain parenchyma. Now this is a contusion. Here you can see the intact pia and the arachnoid matter over here. There is the hyperintense shadow over here surrounded by a hypointense shadow, and that is actually the blood and the edema component. Treatment. patient has to be admitted in the ICU. There's no doubt of admitting in the ward and waiting and watching. Patient has to be NPO, IV fluids on. Anti-epileptics. We as neurosurgeons are very scared of seizures. Every seizure bout kills that many number of neurons and reduces the quality of life in patients. So anti-epileptics are very important. Anti-edema measures, mannitol, Lasix and Dexona if there is edema in the patient. Antacids, as I've already explained. Analgesics rarely, and if the patient is unconscious, ventilation. The third thing is surgical management. Now, if you have seen, all of the management is focused towards reducing the intracranial pressure. We are all trying to reduce the intracranial pressure. With conservative management, if intracranial pressure does not reduce, then the surgeon comes into the picture. Professor Raju was my professor during my training, so I have a few of his anecdotes here. The procedures that we do are external ventricular drain. In the Western countries, they usually put a small probe to know for the intracranial pressure in real time. In India, we don't have that facility. Many a times we do put a ventricular drain and check out the pressure through that. Craniotomy is done to evacuate the hematoma or the contusion in the brain. And the last one is decompressive craniotomy. This is a desperate measure when the edema is going on increasing. All we do is go in and remove the flap of the bone, thereby decompressing the cranial cavity. So a good surgeon is the one who knows when not to operate. So there are some indications for surgery also. So if the extradural hematoma is more than 25 cc in volume, it is indicated. And SDH, subdural hematoma of more than 1 centimeter in thickness, and anything causing a midline shift of more than 6 mm mandates surgical intervention. The aim, as I've said, is to reduce intracranial pressure. This is a picture where the patient had come with a shattered skull bone. There was a large extradural hematoma inside. It was evacuated with the bone being kept outside. So the hematoma was removed and we did put the bone back. It was a decompressive craniotomy that was done. Any procedure or any condition always has complications. Now, why am I telling you this is we are all not gods where we touch patients and patients improve dramatically. We have to keep all this in mind and communicate it to the patient. The first is death itself, persistent vegetative state, persistent neurodeficits, epileptic foci, the confused brain could end up with gliosis. In the rest of the body we have fibrosis, in the brain we have gliosis, and that could be a focus of epilepsy. And last is loss of quality of life. Now, once the surgical treatment and the medical treatment is over, we have to start getting the victim back to his normal life. So rehabilitation forms a very important part of head injury management. So we have physiotherapists, the speech therapy and the occupational therapy doing the job over there. Now, at the end of all these things, we should have an audit for ourselves. What we did to our dear patients, has it been fruitful or no? And that is when the Glasgow outcome scale comes. The chart itself is self-explanatory, where you have death being 1 and a good recovery being a score of 5. Now, I wouldn't like to stop this talk without this last slide, which is, I think, the most important slide in this whole presentation. It is documentation. Today's era is the era of litigation, and documentation becomes very, very important. The first thing is all the cases which are RTS are medical legal cases. Preferably, whenever you document your history and your examination findings, please draw diagrams so that in future when you are asked for any questions, you know what exactly you have come across. Any event in the hospital has to be documented. Necessary consents to be taken only from first degree relatives. And daily counseling definitely boosts the morale of the patient and the patient caregiver. Back to the poll. So, at the end, are all head injuries fatal? Yes, definitely. All head injuries have to be taken as fatal. Treatment of head injury is, I think, useful as it improves the quality of life. All head injuries result in memory loss. Absolutely false. It's the director that is speaking to us. So all head injuries must undergo CT scan. I have given you the indications. not necessarily. There are a few indications which have to be done. And if they survive, definitely it's by God's grace, but also by active human intervention. I am open for questions. Thank you. Yeah, epistaxis could be secondary to a fracture in the base of skull also, but I don't think it should be held back, because I think you will know the distance of how deep the probe can go in. I mean, you wouldn't put it right down inside. So I think you can go to a certain extent and take the scar, which should not be a problem.
So if I may add something, I mean, RT-PCR is done from the nasopharynx. So you are supposed to go straight down along the base of the, base of the nose. If people who do not know how to do it, extremely dangerous. You can get probably the RT-PCR will grow brain tissue. So, that's it. So if you're not like how same rules for ice tube, same rules for everything. So do not, especially when there is epistaxis and you have not seen if there is anterior skull base fractures, better not be done by somebody who doesn't know how to do it. You agree?
Yes, totally agree.
Dr. Lobo, it was an amazing talk, because I'll tell you why. I was looking around to see post lunch how many of them are sleeping. Okay. Actually, everybody was awake. That itself is an indication of how good your talk was. It was also comprehensive. I say comprehensive because I have never seen talks on head injury that involves telling people what to do when they find somebody with an injury on the road. So, nobody really includes that, because I think that's extremely important. Just like telling the relatives of a patient who suffers with seizures, telling them what to do when they see a seizure at home. It just gives them one little bit confidence to, to deal with, to stop and look, even though you're not a neurosurgeon. So I think that's amazing. And also ended with outcome scores. Those are things that nobody talks about when you're given a topic about head injuries, which is also really good. And also, I love the breaks, the seemingly tangential routes, but profoundly important breaks, because it also kept people awake. And if you notice, he's also spoke about cervical spine injuries, even though there was the topic was not about cervical spine. So the reason I feel, if I may add,
yeah, please.
So just to give you an example, to burn it into all of your heads, is I'll give you an example of what happened with me, and I learned it the hard way, and I don't want anybody else to do it. Is cervical spine injuries are permanent. Okay, so if somebody has a cord injury, it's permanent. No amount of money, expertise is going to change that. Keeping that in mind, so when I was a resident in my first year, I had no real understanding of why somebody's neck needs to be strapped in before shifting. So I was called outside the casualty into an ambulance and asked to look at a patient who had a head injury, mild head injury actually. They said, can you manage this patient in the casualty? Because see him in the ambulance and tell us to shift, we'll shift him. I went in, I checked GCS, asked him to move his limbs, he was moving everything. I came out, I said, yeah, sure, why not, move him in. I went in and I was waiting for the patient. 5 relatives carried him, one holding his shoulder, one holding his legs, one holding his waist. They dangled him, brought him into the casualty. He was completely quadriplegic. When I attended to him on the bed in the casualty, that is within 2 to 3 minutes of me seeing him in the ambulance. So when we got the scan, we realized he had a very bad subluxation at C5, C6 level, but the spines were still aligned, and my act of not fixing the spine, he literally changed his life forever. So a simple thing is, assume everybody has a cervical spine injury, fix the spine, then assess whatever you want, because you're going to destroy their whole family. And in probably neurosurgical trauma, the worst form of trauma is cervical spine injuries, because you're conscious, you're awake, but can do nothing with your life. It's worse than having any seizures, memory disturbances, whatever. In fact, those are actually better. You may be living in some form of a bliss, but not with cervical spine.
So assume everybody has C-spine injuries. Maybe make it a hospital policy to put on a collar till you rule out C-spine injuries, then take out the collar, give it for sterilization and put it back in the casualty, something like that.
Thank you. Very good input actually. Very good.
Any other questions?
Thank you, sir, for your enthusiastic and interesting talk. I request the moderator to present a moment.
Now I would like to request Dr. Anjan sir to hand over the memento to moderator. We are now into the final session of the day. The topic for this session is approach to chest injury patient. And to moderate this session, I would like to welcome Dr. Satyamurthy Aikal sir, Professor, KIMS Mangalore, Dr. Dharandya sir, Associate Professor, KIMS, and Dr. Lancelot Lobo, Associate Professor and Unit Chief, Shema.
Now I would like to introduce our speaker, a very passionate and brilliant Dr. Chaitra K. White. He is a popular thoracic surgeon. He completed his FEBS from KMC, DMD from Jaslow Hospital, Mumbai. He did his masters in cardiothoracic surgery from Nizam's Institute, Hyderabad. He specialized in minimum invasive surgery and trained for video-assisted thoracic surgery at Gangaram Hospital, New Delhi. I welcome you, sir.
Very good afternoon to my senior colleagues and to all the audience gathered here today. At the very outset, I would like to thank the organizing committee and Productive Institute of Medical Sciences for inviting me to give this talk today. So the topic for today is approach to thoracic trauma. So let me begin with a glimpse of history. So thoracic trauma is known from ages ago and has been documented in all the medical literature that we have known till now. So to give an example, the earliest known medical document to the present mankind, that is the Indian Smith surgical papyrus, which was supposed to have been written around 1600 BC. So that this surgical text, it mentions about 48 total number of injuries, among which 3 are thoracic injuries, including penetrating trauma, blood trauma, etc. And one of the most well-known literatures of the olden world, that is Homer's Iliad, that also depicts in detail the thoracic trauma which the soldiers had encountered during the Trojan War. And similarly, Hippocrates and Galen, the physicians of Greek civilization, they also came across thoracic trauma, and they said open packing with red meat and honey would help heal the injuries. So the reason why I am giving this is the approach to thoracic trauma has progressed over the centuries. If you take Indian literature, Sushruta Samhita, the best known literature to the world from India, also mentions in detail the injuries faced by a patient in thoracic trauma, and also the consequences of the injuries and the prognosis. Organ-wise prognosis has been mentioned in Sushruta Samhita. So it's not that we are dealing with thoracic trauma today. Thoracic trauma has been seen and treated by physicians all through the centuries. But modern medicine, as we know now, started somewhere around the 14th to 13th century. And Ambrose Paré, he was the first one who advocated immediate closure and facilitation of drainage of blood, immediate closure of the chest wound to avoid pneumothorax. Of course, at that time he did not know the importance of or the pathophysiology of pneumothorax, but he did advocate immediate closure of the wound. And facilitate drainage of the blood using tubes was also advised by him. And he later said a delayed wound closure would help heal the patient in the later days. But it was during World War I and World War II that thoracotomy came into the thoracic surgeons or the physicians' armamentarium. Closed drainage systems were invented, endotracheal intubations along with the endotracheal intubation along with the new systems of anesthetic induction, all this along with blood transfusion. Now these were the things which actually revolutionized trauma surgery or trauma treatment. So if we go back to history, we know that it has been an important management of trauma has been evolving over centuries. So coming to the present scenario, we know that polytrauma causes a lot of mortality and morbidity. So what is the burden that we face presently in thoracic trauma? So if you see world literature, we can deduce that approximately 35% of the trauma in US takes place because of thoracic trauma. In India, it's around 25%. The immediate cause of death is exsanguination. It's a massive loss of blood at the site of accident or trauma. This is pre-hospital death. If we take in-hospital death, that also is, though not as much as in the yester decades, but in the present decades also we can see that patients do reach the hospital, but they succumb in the ICU or the wards due to acute respiratory distress syndrome or ARDS as we know it, multiple organ failure and sepsis. So a lot of thoracic trauma is preventable, and once the trauma takes place, a lot of mortality and morbidity can also be prevented if we catch the catch the patient or the incident at the right moment. So just to have an overlook of the anatomy, the thorax involves chest wall, which is protective in nature, as well as it facilitates respiration. However, excuse me, if you see the age groups, the chest wall consistency differs. In a pediatric age group, the chest wall is very elastic. It has not well-formed cartilaginous structures are more as compared to calcified structures. Therefore, the chest wall is elastic. However, as the age group progresses and patients, we see patients in the older age group, then the chest wall is more brittle. So the chest wall injuries are seen more often in older age group rather than the younger age group, especially pediatric population. So further, the thorax also has the diaphragm, the pleura, the mediastinum. The diaphragm is the lower extent of the thorax. The inlet of the thorax is formed by the base of the neck, okay, and the first rib and clavity. So the soft tissues inside start from the pleura, the parietal pleura and the visceral pleura. Then we get into the mediastinum, which contains the major structures of the thorax. Or there is the heart, there is the tracheobronchial structures, and the major blood vessels and the esophagus. So what is the importance of this? The importance is to know what is in the cardiac box. Well, this is the cardiac box, which I have highlighted there, the red square. Now, cardiac box is formed by, it's an imaginary box which we can get by joining the two midclavicular points and dropping two perpendicular lines to the upper border of the fifth rib. So within this box, if an injury takes place, then the likelihood of it injuring major structures, that is the mediastinal structures that I mentioned, heart, the trachea, the esophagus, is much more than if the injury takes place more peripherally. So coming to the etiology, or loosely speaking, mechanism of injury, because I am saying loosely speaking because each etiology has its own mechanism. But on a broader canvas, we can say that the etiology and mechanism of injury are the same. So there are two main etiologies. There is a blunt injury and a penetrating injury. So blunt injuries mostly occur due to road traffic accidents. 60% of the injuries, blunt injuries, take place because of road traffic accidents. And then there is fall from height, or falls due to slippage or during sports, violence, blast injuries. Of course, in India, the most we see is road traffic accidents and fall. In areas of the world where violence is high and activities of terrorism are high, or war, we see blast injuries and violent injuries. Luckily, we don't see such injuries much in India as much as in other places. Penetrating injuries mainly take place because of gunshot injuries and stabs. Now, gunshot injuries, again, the specific mechanisms are two. One is, it depends on if a handgun is used or a rifle is used. Because a handgun is a low velocity, low energy transfer mechanism. Whereas a rifle is a high velocity and high energy transfer mechanism. So the method of treating each of them is different. However, when it comes to approach to each of these injuries, they are the same. There is no difference. As you approach any other polytrauma patient, the same methods and principles have to be followed here, and a few things have to be taken care of, which I will come to later. So the important thing to note here is blunt injuries are more common, but they have lower operative intervention. Many of them, if detected and treated at the right time, can be treated conservatively and sent home, or with minimal intervention. Penetrating injuries, especially gunshots, have higher overall mortality, though they are of lesser incidence. Just to depict what kind of wounds or what kind of damage each type of injury can cause. So this is a picture of blunt injury. If you can see here, so as I said earlier, the mechanism of injury in subcategories are each other. For example, in road traffic accident, there can be high-speed collision or a motor vehicle hitting a pedestrian, a lateral collision, or there can be accelerating and decelerating injuries. So, if you see this picture here, the blunt injury, this patient has probably sustained a road traffic accident, has been either run over or hit by a car or a vehicle. So, there is a lot of contusion over the chest, and there is evidence of bruising, the loss of skin. He has probably has a pneumothorax, that's why or a hemothorax, that's why an intercostal tube has been placed. So this can also be the result of a rollover injury. If he has been run over by a vehicle, then this can be the picture. Now contrast it with the blast injury, which also is a type of blunt trauma. But you see a lot of burn, see the redness, the erythema over the chest wall. That is because of the burn caused by the blast. So that is, though the injuries inside also have a little different mechanism and pathophysiology, but this is how they present. A gunshot wound to the upper chest, it's the penetrating injury, and a stab injury. Now the difference between this is the gunshot injury is open. So this can cause open pneumothorax, which is a very serious injury. Whereas a stab injury with the object in situ probably gives us some time to salvage the patient. Quickly coming to the pathophysiology of thoracic trauma, because it's very important to know if you don't know the pathophysiology, you cannot approach any disease. That's why in the medical college we learn the pathophysiology of every disease. Similarly, what is the pathophysiology of thoracic trauma? So ultimately, there is respiratory compromise and circulatory compromise. Of course, in any trauma, if you take circulatory compromise is a common denominator. Blood loss is a common denominator. However, this is in a chest trauma, it is due to it's a direct result of injury to the heart or the lungs or the major blood vessels. That's why circulatory compromise is much faster and deadlier. So how does a respiratory compromise occur? It occurs by direct injury to the airway or lungs, number one, or interference in the mechanics of breathing. That can occur due to an injury to the lungs, or fracture of the ribs, or fracture of the sternum, or a flail chest. So these are the causes. So what happens physiologically? Once there is injury to the airway, then there is ventilation perfusion mismatch. What does this mean? Now this we have been reading ever since we have started or picked up our books of physiology. Guyton always mentions ventilation perfusion mismatch. I never understood it when I was in my first year or till I passed my MBBS. So what happens, I come to the specifics of it later, but basically what happens is the amount of air or oxygen that is delivered to the lungs is not transferred to the blood. So therefore, there is a mismatch. Therefore, it's called ventilation perfusion mismatch. It can be the other way around also. If there is an airway injury, the amount of oxygen supply is less, whereas the blood supply is normal. Therefore, again, there is a mismatch. And also, there is decreased pulmonary compliance when there is injury to the lungs, when there is pulmonary contusion. So, ultimately, it results in hypoventilation, hypoxia, hypercarbia, and acidosis. Similarly, circulatory compromise can occur because of direct cardiac injury or decreased venous return if there is a venous injury. And ultimately, it causes hypotension, hypovolemic shock, and acidosis. So, coming to the evaluation and treatment, specifics of treatment or approach to thoracic trauma. Of course, the ATLS guidelines have to be followed, and the algorithm is followed. Polytrauma, that's primary survey, secondary survey, damage control. I'm sure everybody from morning till now has gone over this, so I shall not again go into these specifics. I'll skip the ABCDs. Similarly, I'll skip the secondary survey. So damage control, what is damage control surgery? So once the primary survey is over, so usually the damage control is done after the primary survey or during the primary survey, before the secondary survey. So it's defined as rapid initial control of hemorrhage and decontamination of the injured part. Suppose there is a person, as you saw the picture with the stab knife. Suppose the patient has developed cardiac tamponade. That is the point of time when we decontaminate here, we remove the, of course, take control, stabilize the patient with intubation and all first, and then remove the knife, at the same time stop the hemorrhage. Okay, so that is damage control for that patient. Then pack the wound and close it temporarily. So you resuscitate him, stabilize him till he reaches the operation theatre, and then a definitive treatment can be given. Or you can shift him to the ICU, resuscitate him further, and then a definitive treatment can be given. So, damage control is defined as rapid initial control of hemorrhage and contamination with packing and temporary closure, followed by ICU resuscitation and subsequent re-exploration and definitive repair once normal or near normal physiology has been restored. So what are the immediately life-threatening conditions which require damage control? So if you see this table, there are two things: immediately life-threatening injuries, potentially life-threatening injuries. Whenever you deal with thoracic trauma, most of the times, or 80% of the times, we lose the patient because of immediately life-threatening injuries. The potentially life-threatening injuries in your ATLS algorithm can be dealt with in the last thing, after reassessment and definitive repair. But the damage control and resuscitation takes place for these. So airway obstruction, tension pneumothorax, open pneumothorax, flail chest, massive hemothorax, cardiac injuries, traumatic rupture of the aorta, and air embolism. These have to be taken care of. So how do you do damage control? One of the most important things in thoracic surgery is, or emergency room, is emergency room thoracotomy. It looks very ghastly if you see at the picture. To be frank, I have not done or I have not come across emergency room thoracotomy here or during my training or anywhere during my training. It's very rare to see an emergency room thoracotomy. It does take place in some centers, probably where there is a high volume of polytrauma cases and gunshot injuries which come. It's very rare to see emergency room thoracotomy for blunt traumas. It's usually for penetrating traumas, and that too for high velocity rifle wounds rather than for short handgun wounds. So what are the indications? acute pericardial tamponade with impending loss of vital signs. Exsanguinating intrathoracic hemorrhage, which is also called massive hemothorax. Witnessed arrest unresponsive to resuscitation. So, a patient might have come to the emergency room alive or walking. He has sustained suppose he has sustained a gunshot injury or a knife or a penetrating trauma or a stab. He has come walking to the trauma center, but he collapses there and arrests. Now that is the moment when you do an emergency room thoracotomy. Okay, of course there are indications, other indications and contraindications for that, but this is broadly, these three are the indications for emergency room thoracotomy. What are the goals? Hemorrhage control, release of cardiac tamponade, open cardiac massage, exposure of descending thoracic aorta for cross clamping. That is, suppose a patient who has been brought to the trauma center is having severe hypovolemic shock and is showing signs of CNS injury, or there is decrease in the Glasgow Coma score of the patient. So in such cases, but his vital signs are good, or there is hypotension but can be revived with fluids. In such patients, emergency room thoracotomy can be done so that you can clamp the aorta and decrease the blood flow to the lower limbs, which are much more salvageable than the brain. So when we clamp the aorta, the blood supply is redirected to the brain. Also, EDT can be used for prevention of air embolism, especially in cases where there are pulmonary hilar injuries, and repair of cardiac or pulmonary injury. These are the goals of an emergency room thoracotomy. In fact, because of a lot of difficulty, it's not difficulty, because of the complications involved in doing an emergency room thoracotomy, the contraindications are much more than the indications, especially in this procedure. So what are the contraindications? Very important that you should not, for any patient who comes to the trauma center, you cannot do an emergency room thoracotomy because the patient is going into a system, or is having an arrest. No, don't do it EDT. So what are the contraindications? The vital signs are present, including detectable but hypotensive blood pressure. Futile situations, like there are no signs of life on the scene of injury, then the EDT will not help. If the patient is pulseless for more than 15 minutes, EDT will not help. He presents with asystole or already has arrested, then there is no point in doing EDT. Similarly, important thing is if the appropriate resources are not available, then do not go, because it will become a misadventure rather than helping. Okay, so if you don't have a manual internal defibrillator, then do not do a emergency room thoracotomy. Similarly, penetrating abdominal trauma without cardiac activity, severe head injury, severe multi-system injury, and pediatric and aging population. So these are the situations where EDT will not help and therefore is contraindicated. Just to give an overview of how does the emergency room thoracotomy look, I have put a video taken from YouTube. Now this patient had a stab injury to the precordium, blood pressure was unrecordable, there was no breathing, but the pupillary response was good. Therefore, so this is how it is done. It is not a pretty sight. It's very crude and has to be fast. Otherwise, there is no point. By the time you open up the chest, patient would have collapsed. it's a little grainy because it's an old video. It's a 10-year-old video. No other video is available. Now, resource availability. Now, if your emergency room does not have resources for a thoracotomy, what do you need for a thoracotomy? You need, first of all, a rib spreader. So the instrument that the surgeon has put there is a rib spreader. You should have a setup similar to the operation theatre, though not equal to, because you should have basic instruments, cutting instruments, clamping instruments, suturing instruments. So once EDT is always done in the anterolateral via anterolateral thoracotomy, and if required, the incision can be extended to the opposite chest wall, and the whole chest can be opened like the bonnet of a car. It's called a clamshell thoracotomy. Like a clam opens up its shell. Similarly, a clamshell thoracotomy can be done if bilateral hemithoraces have to be exposed. So if you see here, this gentleman had a stab injury and a penetrating cardiac trauma. So the surgeon here is exposing the heart. I'll just forward it a bit, it's a long one. The heart is exposed. There. The surgeon has put his finger into the hole in the heart and stemmed the bleeding. Now we'll ask for a Foley's catheter so that he can insert it and expand the balloon and yank it against the hole and tamponade. The tamponade effect closes the hole and closes the bleeding. And also very important is availability of blood and blood products. If you do not have a blood bank in your setup, please do not attempt any kind of such procedures in your setup. So a Foley's has been inserted and the bleeding has stopped. Now this patient, now the clamps cannot be removed, the retractors cannot be removed. The patient has to be taken like this, and the trolley has to be taken to the operation theatre directly. So he has been taken to the definitive the operation theatre, and this is what is happening. There. The surgeon is suturing the rent in the cardiac free wall. In this patient, luckily there was only, he could get away with a direct suturing and a beating heart. There are certain injuries will be still severe, so they will require cardiopulmonary bypass. So all this should be available, and then only we can attempt to do a emergency room thoracotomy. So the suture has been placed, the Foley's has been removed, and the patient has been saved. Okay. So when do we refer the patient to a thoracic surgeon? So why is this important? It is important because most of the thoracic centers or casualty departments will not have a thoracic surgeon at hand. Who mans a trauma center? It's the emergency physician or the senior residents. So when all these measures that we mentioned in the ATLS guidelines, they should be conversant and able to do all these procedures like passing an intercostal tube, doing needle thoracentesis, basic suturing, cervical spine stabilization, log rolling of a patient. All these things should be known to the person who mans the thoracic center, trauma center. So when does the thoracic surgeon come into picture? The thoracic surgeon comes when the blood loss over the chest or a chest drain is more than 1500 ml at initial insertion of the intercostal tube, or over a period of 4 to 5 hours, more than 200 ml is drained every hour. Also, if the patient has hemoptysis, now this is an indication for tracheobronchial injury. Therefore, if hemoptysis is there, call a senior or call a thoracic surgeon. Massive subcutaneous emphysema. This again is an indication of either a tracheobronchial injury or an esophageal injury. Therefore, refer to a thoracic surgeon. Important air leakage over the chest tube. Uncertain images on chest X-ray or CT thorax. Penetrating chest trauma. These are the indications where a thoracic surgeon has to be consulted. Indications for urgent thoracotomy. Again, massive bleeding, large unevacuated pneumothorax, cardiac tamponade, chest wall defect with ventilatory compromise, that is open pneumothorax, a massive air leak with incomplete lung expansion, great vessel injury with hemodynamic instability. So I'll get into this, a few specific injuries which are important to be dealt with in the emergency department. So tension pneumothorax. How do we recognize a tension pneumothorax? When this is basically a clinical diagnosis. We cannot wait for a chest X-ray. By the time a chest X-ray is done, the patient has already collapsed. So how does the patient present to you? It's important to recognize that. A patient will be in respiratory distress. He will not be comfortable either sitting up or lying down. He will be agitated. He will not listen to your commands. You will want to put an IV line. He will not give you his hand. He will be sweating profusely. So at that moment of time, listen to his breath sounds. Palpate his trachea, see if there is any deviation of the trachea. Auscultate. Sometimes auscultation is not good in the casualty because there will be a lot of commotion. So you may not hear chest sounds properly. What you can do, you can percuss the patient. Percussion, if you hear a tympanic note, then it is a pneumothorax. And also there will be a bulge over the hemithorax where the tension pneumothorax is there. So immediately what has to be done? The treatment is a needle thoracentesis, which is a temporizing measure, of course. The treatment is intercostal drainage. So this is a chest X-ray of how the patient, the tension pneumothorax. There is the collapsed lung. The hyperlucent area is, so this is a left-sided tension pneumothorax, a completely collapsed left lung. The trachea, if you see here, the trachea is deviated in this patient. So the trachea is deviated in this patient to the right, as well as there is a mediastinal shift. So this is how you diagnose a tension pneumo in the X-ray. But however, a patient who survives a chest X-ray with having tension pneumothorax is very lucky. So tension pneumothorax is a clinical diagnosis. So how do we do a needle thoracentesis? We put a needle into the second intercostal space in the mid-clavicular line, a 14 or 16 gauge. Now what has to be, an easy way of doing it is, do not take the needle directly and puncture it into the chest. Connect it to a 10 cc syringe with 5 to 6 ml of saline, and then with aspiration go in. So that way when you enter the thorax, or when you enter the pleura with air in it, you will get air bubbles. Otherwise, in the patient who has thick chest wall, it's difficult to gauge how deep to go. And studies have shown that at least 60% of the needle thoracentesis done in the trauma center does not work. It has a negative result. We think that we have gone into the chest, but actually we have not. So the gush of air, which is supposed to have heard or felt, most of the time in the commotion, when the polytrauma comes in, we cannot make out. So the best way is attach a needle with saline and aspirate, hit the area of air, and then remove the syringe, let the needle drain. Now, this picture I have taken from a journal or an article from the Emergency Medicine Journal. This was published in 2004, but it is relevant even today. This was a study which was done to find out the efficacy of needle thoracentesis, or the knowledge of emergency physicians to do needle thoracentesis. Now, if you see here, I will show the article later. Now, 25 people were taken for the study, and in the normal healthy volunteer asked to identify the second intercostal space. Out of the 25, only 15 could identify, and the rest of the other 10 could not identify the second intercostal space. I am not talking of the procedure being done, they could not identify the second intercostal space, which is a basic thing we learn in surface anatomy in first year MBBS. So this is the angle of Louis, and the rib adjacent to it is the second rib. That is what we know. And the space immediately below it is the second intercostal space. That is where, in the mid-clavicular line, you are supposed to go and put the needle. Now the black dots you see here, that is from the study actually, where most of the people put the needle medial to the mid-clavicular line, not over the mid-clavicular line. The problem is, you can injure medially located structures. In the patient of polytrauma, everything will not be in its anatomical position. The aorta might have shifted, the cardia might have gone up, or there might be intercostal vessel, there can be the internal mammary artery. So you can always hit any of this, and instead of saving the patient, you can end up harming it. One person had also put marked here within the fifth intercostal space. Actually, this is the correct way of doing it. Though textbooks do not mention it, of late, a lot of literature is coming up, or they are mentioning it at least, that a fifth or sixth intercostal space in the mid-axial line, needle can be passed to relieve the patient of a tension pneumothorax, because the chest wall there is a lot thinner. Only the intercostal muscles are there. There are no other muscles. There is no pectoralis major. So you can easily go into the chest. That is much easier rather than putting it over the, and there are no major structures also. Especially in the patient with pneumothorax, even the heart does not come there. So you can easily put it the fifth intercostal space in the mid-axillary line. This was the original article which was published. So coming to open pneumothorax. What's the open pneumothorax? This is how injury with open pneumothorax looks like. This is most often encountered when a patient comes with a gunshot injury, or usually a gunshot or rifle injury, or a shotgun injury. So what happens is the portion of the chest wall is lost, is absent. So there is direct communication between the negative pressure pleura and the atmosphere. So there is sudden gush of atmospheric air into the pleural cavity, and the lung collapse is sudden. So because of this, a patient's cardiovascular system cannot take the extra load, and the patient collapses. a slow or a simple pneumothorax develops over a period of time. Therefore, the patient's circulatory and circulatory system can take the pressure. However, in this case, they cannot and they succumb. This is also called a sucking chest wound. Now, suppose the patient has a flap over the wound, then the flap can partially stem the gush of air from atmosphere into the chest. So that's why it causes a sucking noise, and therefore it's called a sucking chest wound. Of course, once the pressure in the chest wall and the atmosphere are equalized, then it is no more a sucking wound, it is an open pneumothorax. So, one of the conditions which can be fatal to the patient. So, how do we treat that? It is very simple. Just put a 3-sided occlusive dressing. Though it is a very ghastly wound, it can be easily controlled by putting a 3-sided occlusive dressing. So, simple polythene or any membrane can be used, kept over the wound and close it by 3 sides. Now, this acts as a wall. When the patient breathes in, because of the negative pressure, the thin membrane, it gets sucked onto the chest wall, onto the wound, and it closes the wound and prevents the atmospheric air from going in. Okay, so this is a simple method to temporize the open pneumothorax. The treatment is, of course, intercostal tube drainage. Once the intercostal tube has been placed, patient has been stabilized, this wound can be dressed, sutured or closed. Cardiac tamponade, one more deadly complication of a thoracic trauma. Here there is accumulation of fluid in the pericardial space, resulting in reduced ventricular filling and subsequent hemodynamic compromise. Clinically, it is detected by the Beck's triad. That's hypotension, raised jugular venous pressure, muffled heart sounds. But clinically relevant thing here is hypotension only, because again, in a patient who is hypovolemic, probably raised JVP may not be there. A patient who has come into a very busy trauma center, muffled heart sounds are very difficult to hear. So hypotension has to be, the patient's pressure has to be checked and hypotension has to be caught early and it has to be treated. It is treated by 2 methods, either by a needle thoracentesis or by an open method. So how do you do a needle pericardiocentesis? This is done by a sub-xiphoid approach. The needle is inserted between the xiphoid process and the left costal margin. Aim it at the mid-clavicular point, at the left mid-clavicular point, and direct anteriorly towards the right ventricle. Aspirate, and just as I mentioned, to put the needle into the needle thoracentesis. Similarly, aspirate and go in. The moment you get a give way, you will find that blood or fluid which is there in the pericardium will come into the syringe. And similarly, at the same time, the patient's condition improves, the blood pressure comes up because the heart finds more space to beat. The pericardium, in the acutely injured pericardium, will not be able to expand. Therefore, only about 50 to 100 ml, if blood is collected in the pericardium, then the patient can have hypotension, can have cardiac tamponade. Therefore, this is a procedure which will have to be done at the earliest, and you cannot wait for anybody. If you have an ultrasound machine in your center, then it is good, because then you can, as the other speakers would have told you, can perform E-fast. Once you do E-fast, you will know that pericardial tamponade has happened, and you can do this procedure under guidance. If it is not present and you are not equipped to do a needle thoracentesis, it can also be done by a surgeon by the open technique. How do we do it? Sub-xiphoid approach again. There is the linear incision is taken about 5 centimeters in length. Linear alba is exposed. The xiphoid process is exposed. The xiphoid process, if required, can be cut. And once that is done, a little bit of finger dissection will just put you on top of the pericardium. The pericardium is held and cut using scissors. Once it is cut, the pressure is released and the whole blood is drained out. Coming to massive hemothorax.
Again, you don't suture that.
Pardon, sir?
Pericardium, you don't suture that, you just.
Yes. You can't, we do a window. This is a pericardial window. So there is no suturing here. The pericardial window is kept open so that all the blood drains out. Now, of course, this is a temporizing measure. It has to be kept open till the patient is taken to the operation theatre and the definitive procedure is done. Now, you can also place in a drain. Of course, it does not have to be kept open till you take the patient to the. You can put in a drain, put in a tube drain, or you can put in a corrugated drain. Now, that will keep the window open. You don't have to suture it. You keep the window open and let it drain. Massive hemothorax. The most common causes of massive hemothorax are internal mammary artery and intercostal artery injury. Now, what is a massive hemothorax? First of all, now the chest cavity, each heavy thorax can accommodate up to 3 to 3.5 liters of blood or fluid at a time. So, when you see a chest X-ray, it looks like this. Haziness on one side, then that is indicative of a pleural effusion, of a massive effusion. Again, there will be mediastinal shift. If there is no mediastinal shift, then it is deemed a simple pneumothorax. Simple hemothorax. But if there is mediastinal shift, then you can call it a massive hemothorax. What is the treatment? Intercostal drainage, fluid resuscitation, blood transfusion, if required. That is, rarely when there are aortic injuries or cardiac injuries, the patient can bleed into the pleural cavity, and in such situations, emergency room thoracotomy may be required. However, taking care and making sure that you have all the resources at hand. Flail chest. Now, this is one of the conditions which, as I mentioned earlier, is very much preventable cause of hospital death. Flail chest rarely cause death at the scene unless the patient has a massive other system injury also. So how do we define it? Fracture of at least 4 consecutive ribs in 2 or more places on one side or both sides of the sternum, including the sternum. That's how it looks like. That is a flail segment. The 4 ribs which are fractured, and this segment is separated from the chest wall. Now, this segment is the cause for all the problems. Now, though the definition says that at least 4 consecutive ribs are involved, should be involved. Now, a flail can happen, as I said, the age of the patient is very important. Now, in an older patient, and the physiology of the patient. All patients coming to the trauma center will not have normal physiology. They might be having comorbidities. He might have undergone, he might be having a cardiac condition, he might be having severe COPD. So in such cases, this definition does not hold true for every patient. Therefore, the trauma consensus came up with the functional definition. What they said was an incompetent segment of chest wall large enough to impair respiratory dynamics. So a patient with chest wall injury, even with 2 rib fractures at 2 places having a flail segment of 2 ribs, if he is an elderly man, the pain and his comorbidities may not allow him to breathe properly. Now that is enough to cause respiratory failure. Therefore, it's important to keep in mind the definition as well as anatomical as well as the functional definition. Example of a flail chest. This is how the anatomical definition looks like. So that's a flail chest. Since there is a free floating segment of chest wall, when the patient breathes in, the chest wall collapses inside along with the negative pressure of the chest. And this is the one which causes problems. So pathophysiology, floating chest wall segment, paradoxical motion during respiration, further causing reduction in vital capacity and ineffective ventilation. Also, because there is chest wall trauma, the underlying lung is injured. Therefore, there is pulmonary contusion causing ventilation perfusion mismatch. Ultimately, there is respiratory failure, hypercarbia, and patient death. So, pictographically, this is how I just want to explain it clearly. So, flail segment. Now, here there is underlying lung contusion. So, when the patient breathes, the flail segment collapses in along with the negative intrathoracic pressure. It is sucked in. So, therefore, an already injured lung is again compressed by the overlying segment, flail segment. So therefore, now the air which is coming into the lungs, it is not utilized by this contused segment of the lung. So there is ventilation, but there is no perfusion here. Or even if there is perfusion, the alveoli are collapsed. Therefore, the air does not reach the alveolar bed, capillary bed. Therefore, perfusion is there. However, ventilation is deficient. Therefore, ventilation perfusion mismatch occurs. At the same time, there is one more thing happening here. That is, when the patient expires, the flail segment moves outwards, and that portion of the lung also moves outwards with it. Now, the air from the opposite lung, which has to go out a little bit, seeps into this lung. So therefore, the expired air, which is rich in carbon dioxide, again goes into the normal part of the injured lung. So that also gives, partly is responsible for the hypercarbia or ventilation perfusion mismatch which occurs in the flail chest. So this is the pathophysiology, and therefore very important that flail chest has to be recognized and treated early. So how do you treat, how do you manage in the emergency department? Early mechanical ventilation is the gold standard. So it can be invasive or non-invasive, depending on the severity of injury and again the age of the patient. If it's a pediatric patient, an older age group patient, then invasive or non-invasive ventilation has to be done. Invasive ventilation means patient has to be intubated and connected to a ventilator. Non-invasive ventilation is a patient connected to a ventilator without an endotracheal tube by way of a mask. A mask is put onto the face. I should have put a picture, I have not put a picture of that. So that is non-invasive ventilation. NIV, which is in short we call it NIV. Analgesia is very important in the treatment of flail chest. Treat associated chest condition. Very important point is proper fluid management. Any thoracic trauma, fluid management has to be perfect, not less than perfect, because an injured lung is very sensitive to fluid exacerbations. When even a little extra fluid given directly goes into the third space and third space is in the injured lung. Therefore, the patient will have unilateral pulmonary edema, and it's very difficult to take the patient out from the ventilator once he has developed unilateral pulmonary edema. In fact, even in elective cases, this is proper fluid management is very important in a thoracic specialty. Operative repair is indicated when there is persistent pain, severe chest wall instability, progressive decline in pulmonary function, patient cannot be weaned off from the ventilator. Then in such cases, operative repair of flail chest has to be done. Or if the patient is undergoing thoracotomy for other injuries, then at the same time, fixation of the ribs can be done. So this is how a flail chest fixation looks like. This is the initial X-ray, intraoperative picture, the post-operative picture. So with this, we have covered most of the injuries which we see commonly or everyday trauma center duty rotation. So other injuries like cardiac injuries, tracheobronchial injuries, these are much rarer, mostly because we don't see them, they don't reach the trauma center. Most of the time these are exsanguinated at the site of injury itself. So what are the cardiac injuries that you can see? From contusion up to myocardial infarction, anything can be seen. So contusion. So these are the cardiac injuries, most of which will not reach the trauma center, but if reached and patient is alive, if you have the resources, do a EDT, and if you can salvage the patient, take him to the operation theatre. Treatment is by, first thing is high degree of suspicion, pericardial window, ER thoracotomy, and supportive anatomes. Aortic injury again, 80 to 90% of the patients do not reach the trauma center, they die at the site of injury. Just highlighting this X-ray, if you see a patient with this X-ray picture, see there is a mediastinal widening, the red arrow. The left bronchus is pushed down. That's because of the hematoma or the aorta here, which has ruptured, and there is loss of aortic knuckle and loss of aortopulmonary window. So these are the four signs which should indicate aortic injury. And this sign is called left apical cacking. So when there is rupture of the aorta here, blood can clot onto the left apical area and give this picture. So this is not a loculated effusion, but this in a trauma patient is a sign of a aortic injury. Because most common site of rupture is ligamentum arteriosus. Treatment is permissive. In the trauma center, you cannot really do anything, or in the casualty. Permissive hypotension, maintain the blood pressure at 90 to 100 millimeter mercury, give beta blockers, shift the patient to operation theatre for open surgical repair. Or if you have a good cardiology setup who do a lot of interventional procedures, then a stent grafting can be done. Tracheobronchial injuries, again, very low incidence. Blunt force is the major cause. Penetrating, less likely in the thorax. Penetrating injuries of the trachea are more common in the neck rather than in the thorax. Treatment is treat tension pneumothorax, mechanical ventilation, and later definitive repair by debridement and tension-free primary end-to-end anastomosis. Esophageal injury, again, present by either pneumothorax, pneumomediastinum, subcutaneous emphysema, all this. Very rare in thoracic setting. treatment of the thoracic esophagus injury is by primary repair with intercostal muscle buttress, provided the patient reaches the casualty within 6 hours of injury and the injury is detected. If it is later, then it's better to do a triple drainage. That is, drain the site of injury, put a drainage into the esophagus, get it out through the pleura, and drain the pleura as well as drain the mediastinum, because there will be contamination of the whole thoracic cavity. So triple drainage is very essential. And depending on the site and the severity of injury, a cervical esophagostomy might be required. That is, the esophagus at the site of injury is detached and the proximal part is brought out from the neck and made into a stoma. This is not divided. It is left as it is within a stoma bag or a colostomy or ileostomy bag. So this way, if the blood supply, whatever remnant blood supply is there, then the extra, the area of the esophagus which does not have the blood supply necroses off, and the healthy area remains behind and later can be used for repair. Mind you, one important thing in patients with esophageal injury, stomach is a very important conduit for reconstruction. Therefore, a feeding gymnostic has to be made for nutritional purposes, and please do not do a feeding gastrostomy for this patient. Final topic, final heading is air embolism. It carries a high mortality, most common in blunt trauma. It can be venous or arterial. What we are concerned about is arterial. Venous is not very it's manageable by the patient's system. However, when there is arterial air embolism, then it causes CNS problems or myocardial infarction also. Clinically very difficult to recognize. Patient will come with circulatory collapse, cerebral events, or sudden death in a conscious patient, or he can present with pulseless electrical activity. It can be detected by a 2D echo. Treatment is to maintain low airway pressures, give 100% oxygen because it is more soluble than the other components of atmospheric air, avoid hypovolemia, avoid nitrous oxide if the patient is to be taken for anesthesia. Do an immediate thoracotomy if required when there is suspicion of hilar injury to take control of the injured lung, hilum of the injured lung, and arrest the passage of air into the vascular system. So this in broad is how we approach a patient with thoracic trauma. Thank you.
You have listened to a very informative and lucid talk on the how to approach thoracic injuries by Dr. Chaitra, but it was really appreciable, and congratulations from my side. Floor is open for discussion.
The question is to Dr. Satyamurthy. Sir, in an emergency case, whether a surgeon can do a thoracotomy or a put an intercostal drainage, if at all done and patient is dead, is it a medical legal situation? What is the
Very complicated one actually. I mean, chest tube drainage we can do because we are.
If I can answer, sir, no, it is not medical legally relevant. General sir,
because sir had experience, so I asked him.
No, it was a medical legal case where I put this one, intercostal drainage. Then during cross examination, because the patient I think is not, is dead, not dead, but we put the case against the one who was stabbed. So the opposition lawyer was asking me whether you can treat this case because you are just MS. Are you a cardiothoracic surgeon? So they said we have some 2-3 months of training in cardiothoracic, so we are able to do because you are permitted. No. My question is, are you a cardiothoracic surgeon? What I can say? I could not answer his question because it was deliberately was asking to get the favor to his side.
Yes. No, any patient, any life-saving procedure can be done with by any doctor with the basic degree.
Even not necessarily MS.
MBBS graduate. That is why internship is important. These things: tension pneumothorax, massive pneumothorax, flail chest. These are the things which even the intern has to know how to treat. So that's why this CME is very important, because approach to polytrauma is for everybody. It is not a specialty topic, to be frank. It is a basic topic. So that's why I put a slide. When do you refer to a surgeon? So if you have a massive hemothorax, if the drainage is 1500, that means the ICD has already been placed. If there is a tension pneumothorax, radial thoracentesis has to be done. You can't wait for a specialist to come and do the procedure.
This question comes when you are flying in the air, remember. Those who have COPD patients, suddenly they develop pneumothorax.
Yes.
So then usually immediately the air hostess will come asking any doctors, not necessarily specialists.
Thank you, Dr. Chakrabarty. Very nice and informative lecture you have given. Approach to chest injury in a polytrauma.
Thank you.
Just now I want to ask, you have done, you told one study, they have done 25, is there interns or is
No.
there 25 people, only 15 people are able to identify second intercostal space?
Among these, none of them were interns. Eight among these were
In
consultants.
which country? Is it in India?
No, this is of course not. Of course not.
That's a serious matter. Because our interns should know the intercostal space correctly, sir. Actually, this is all the interns who are working in here. They should know this. So many times in polytrauma, patients must have lost their life because of not identifying the pneumothorax. So I just want.
I totally agree, sir. That's the very reason why I put this slide. If you see here, 25%, 25 emergency physicians were studied, 21 of which were ATLS certified.
ATLS certified people are not able to.
Exactly. So if you see the conclusion, should greater emphasis be placed on competency
In this situation, what I am telling you, we should be serious. It is our status of our Indian graduates.
Maybe after the banquet. After the banquet, when so many surgeons put together, so after the banquet.
Study done in Ireland, sir.
Ireland.
Status of Ireland.
So, though the study was done in 2004, it still holds true.
Okay.
Thank you, sir, for your informative session. Now I request the moderator to hand over the momentum.
I would like to request Dr. Augustine sir to hand over the momentum to Dr. Lancelot Lobo sir. Vincent sir to hand over the memento to Dr. Dharamveer sir. I would like to request our MS, Dr. Devidas Shetty sir, to hand over the memento to Dr. Satyamurthy Aikaraj sir. Thank you, moderators. With this, we have reached the end of today's session. I would like to inform all the registered delegates that 2 points will be credited to you, and your respective certificates will be sent to your respective department hospitals by Monday or Tuesday. And the delegates who are spot registered today can collect your certificates in the registration desk. I request everyone to please rise for the national anthem. Thank you, everyone.